So good afternoon, everyone, and welcome to the Health and Government Operations Committee. The chairman is Chairman Pendergrass, and my name is Jocelyn Pena-Milnick. Thank you so much for coming to our members, and I hope you had a great weekend. We have a full list of bills today. Hopefully they'll go fast. And I would like to just go through some of the rules. This is a virtual committee meeting, so I ask you for your patience if something doesn't go right. The bill hearing is being streamed on the Maryland General Assembly YouTube channel. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of 1 question and 1 answer for the panel, not 1 question and 1 answer for each individual panelist. Also, please keep your questions shorter than the expected answer. The bill sponsor or a designee is allowed 5 minutes to present the bill. 5 witnesses each will be allowed to speak for 2 minutes in support. 5 witnesses if there are actually favorable with amendment, 5 witnesses if we have them in opposition. And of course, you can submit as many people as you want in writing, and we do read it, so it's important. We do pay attention to them as well. So please conclude your remarks when you see the timer that our staff, Richard and Susanna, keep. And members, please remain present with your video camera on during the entirety of the hearing. I know that some of you are a passenger in a car, not driving, and will be at your desk soon. So I understand that you would, as soon as you get to your desk, put the video on. So let's get started. So we have first House Bill 1193, followed by 1222, 1243, 1185, 1188, 1192, 1170, 1176, 1213, 1214, and the last bill of the day, 775. Susan, actually, no. Then after that, 1329, and the last bill of the day, 1381. Susanna and Richard are amazing, and they let us know in the chat what bill we're on and what's the next bill if you're lost on the agenda. Let's start with House Bill 1193, and it's my wonderful colleague, Delegate Saab, Anne Arundel County Licensing of Food Establishment Waiver for Open Air Food Market. Delegate Saab, will you be so kind? And you can get started.
Thank you, Madam Chairman. Good afternoon, members of the HGO Committee, my home committee. And for the record, I'm Delegate Sid Saab, testifying on House Bill 1193, which is the licensing of food establishments waiver for an open air market. So some of you may remember this bill or a similar bill from last year that came in as a statewide bill. This year, I'm bringing this bill back to this committee as a local bill. And in the interim, we have worked to address some of the issues that were brought up during the testimony. And after working with Councilman Hare and also with the council of the Anne Arundel County delegation, we have narrowed down to a solution to an issue that open air market were encountering. To give you a little bit of background about the benefits of open air market, and experts suggest that as a preventive measure during the spread of COVID, that people are less likely to catch virus in an outdoor setting. Open air markets therefore provided a safer way for shoppers to congregate and buy locally sourced products. And many people turned into this local open market during the height of the pandemic to avoid the crowded grocery stores, especially our older population. And while shopping in an open market has grown to be more attractive in Anne Arundel County, some businesses ran into some roadblocks with qualifying for their food service retail business license. So unfortunately, some of those rules prohibited those small businesses from getting a food service retail license because some of the regulations that applied, such as flooring material and lack of a 3-compartment sink, prevented them from getting the license. And this bill was brought to me by Councilman Hare, that one of our constituents reached out to her, and this specific open market was selling refrigerated items that was already vetted. So these are locally sourced from local business that has already undergone the proper safety measures. So the health department came in and told them that they couldn't sell prepackaged product because they don't have a food service license. So even though this business has high quality refrigeration, a cottage food license, and again, they're selling items from locally sourced vendors that already have gone through the vetting from their respective authorities, they still need to spend an absurd amount of money to have specific kind of flooring and a floor that doesn't even make and a 3-compartment sink that doesn't even make the product any safer. And so since MDH, the Department of Health, delegates licensing authority to food establishment to the local health departments, this bill is necessary. So what this bill does, it enables the county and gives them the flexibility to exempt certain requirements, such as the sink and the flooring. And it gives them the flexibility. And so the health department will have to develop a process and they can control that process. So the language of the bill is very clear that this is an enabling legislation. And this is a good bill for local businesses. It also helps our agricultural community. And again, this is enabling. And we want to make sure that those businesses are able to sell the locally sourced items. So I don't want to talk too much because I'm going to cede the remainder of my time to Councilman Hare. But with that, I appreciate the time and I thank you for allowing me to squeeze in Councilman Hare to just take the remainder of my time. And I ask the committee for a favorable report on House Bill 1193. Thank you, Madam Chairman.
My pleasure. Council Member Jessica Hare, good afternoon.
Good afternoon. Thank you so much for having me.
Our pleasure.
I'm going to just follow on Delegate Saab's comments. My takeaway from the discussion last year was threefold. Most folks agree that there is a need and a desire for these local open air markets in the community. Folks agree that there's a disconnect between the existing law and the inherent nature of open air markets and their inability to meet the requirements of the food service license. And then folks agree that this is an issue statewide, but that different counties face unique challenges. What Delegate Saab has put forward here is a plan that offers flexibility and the ability for the local governments to work in cooperation with the constituency to address the needs of every individual, locally. And I want to make one really clear important point. This bill, it says they may grant waivers. It's not a shall. This is not an unregulated circumstance. Any comment that, this would somehow allow massive amounts of unsanitary, unsafe foods to be served is just not supported by the evidence. These businesses will still have to apply for a license. They'll still have to work with the local health department, but it gives that health department the flexibility. So I ask your support in this bill this evening or this afternoon. This is a vote in favor of our communities, in favor of our small businesses, in favor of our farmers, and in favor of local government working in concert and in cooperation with its constituency. Thank you.
Excellent timing. Wow. Thank you. Are there any questions for Delegate Saab or Council Member Jessica Hare from the committee members? So if you go, raise your little hand. Okay, I have Delegate Kaiser followed by Delegate Riley.
Thank you, Madam Chair, and thank you, Delegate Saab, for this bill. And I heard you mention wanting a waiver in regards, if I heard you correctly, in regards to like flooring or sinks or something else. But why are those things even knocking places out of getting the ability to have an open air market in the first place?
I think obviously that's one of the reasons we need to update our regulations. And I believe if you were already manufacturing or preparing the food on site, those are some of the requirements. But since there isn't a special section in the code for open air market, they ran into that issue. So what this bill exactly will do, it'll just create that waiver for those specific unneeded requirements that is preventing them from selling stuff that's already been, or products that's already been gone through. I mean, they were manufactured in a facility where the local health department has authority over. Those are the same items that you can buy at Wegmans or at Harris Theater or Giant. Those are the same items. It's just they're being sold in a different place.
Thank you.
I appreciate the question.
Delegate Riley, followed by Delegate Johnson.
Thank you, Madam Chair. Yes, to Delegate Saab. So these items that are made at a licensed facility, okay, and now the open air is just buying them from the manufacturer, whatever, retailer. So they're completely enclosed in a container, or so they're not open to any kind of air and transportation, correct? I mean, they're
correct. These are all items that have already been They're just purchased for retail, for resale.
Okay, so they don't have to be cooked and they don't have to be wrapped. They don't have to, no maintenance whatsoever, just sit them on the shelf.
Correct, not from the retailer.
Okay, thank you very much.
Thank you.
I like it.
Please. Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate Saab, because I like this bill. It's kind of the same question Delegate Riley asked, because I saw the Anne Arundel Department of Health. Their concern was that it would allow businesses to provide potentially hazardous food and wouldn't have the ability to wash their hands or surfaces. But you stated that none of this is raw exposed food. Everything is packaged and wrapped, correct?
That's correct. And with all due respect to them, I tried to reach out to the health department this morning, and also Councilman Mehu has attempted to reach out to them because we think they misunderstood what the bill is really does. Because again, they still have to develop the process, and they can develop the policy and control the process. So, I'm hoping that maybe with all due respect, if they understand that the bill is enabling and they still have the authority, they would change their status from opposed to support.
Reading their concern, that's what I thought. Maybe they misunderstood the bill. So thank you. Thank you, Madam Chair.
Thank you.
My pleasure. Are there any other questions from the committee? Okay, for this panel, seeing none, thank you so much for being with us. We now have an unfavorable panel, Mr. Donner Curtin. Good afternoon, sir. You have 2 minutes.
Hi, I'm Don Curtian, the Director of Environmental Health for Anne Arundel County Department of Health, and the Department of Health and the Maryland Conference of Local Environmental Health Directors oppose House Bill 1193. Also, the 24 health officers also join Anne Arundel County and the conference in opposing this bill. The Anne Arundel County Department of Health and the conference have concerns and apprehension that the adoption of this bill would allow for unregulated facilities to serve potentially hazardous foods, which could increase the incidence of foodborne illness through diminished food safety. This bill would also allow a business provide potentially hazardous foods to its customers without the ability to wash hands, wash surfaces, and any items that could come in contact with these foods. An unwashed or unsanitary surface is one of the easiest and most common ways to contaminate foods. Local health departments regulate and inspect licensed food service facilities to assure foods are kept at proper temperatures, are prepared under safe and sanitary conditions, and are obtained from approved sources. Waiving these requirements would increase the risk of foodborne illnesses, potentially putting all Marylanders at risk, including vulnerable populations, children, and the elderly. Food safety regulations are in place to provide the minimum standards necessary to reduce the risk of foodborne illnesses. If these regulatory protections are removed, the business is at an increased risk of liability if any illness occurs from the consumption of food products. This bill also uses the term open air market, which is not defined. Accordingly, the Anne Arundel County Department of Health, the Environmental Health Directors, and MEHU request the committee to give an unfavorable for House Bill 1193. Thank you for your time this afternoon.
Thank you for your time with us. I'm going to now open it up for questions from the committee members. Are there any questions for this witness? First, we're going to start with Delegate Saab, followed by Delegate Chisholm. Delegate Saab.
Thank you, Madam Chairman. Mr. Curtin, thank you so much for being here. When you get back to your office, probably hopefully see my message. But so some of the concerns that I have, and obviously I see that you mentioned a few things in your letter, and then you reiterated. So the question that I have to you is, how is it a 3-sink makes any difference than having 1 sink or 4 sinks? So obviously we tend to agree that there might be some outdated requirements in the concrete. And if this, to your point, if this is about food safety, the health department still has the authority to develop certain regulations to address your concern, and you can still control the process by being specific by telling them, we need 2 sinks instead of 3 sinks. So the issue that we have with the current code is that the law currently said that you have to have 3 sinks, which is, as the delegate brought up earlier, that it's not justified by rationale and the flooring. So why are you still opposed to it if this is just gives your department the flexibility, and it also gives you the ability to control the process by just allowing you to waive it on case-by-case condition or base?
The concern with the 3-compartment sink is when you have utensils there, the 3-compartment sink has different sets so that you can wash and sanitize and have them sit for a certain period of time to make sure that any contaminants and bacteria are killed off. The concern that we have with Anne Arundel County being able to write these regulations is we already have a food code that is statewide that already spells all this out, that all the other jurisdictions follow. Having a separate set of regulations or criteria in Anne Arundel County can be very confusing for businesses because they already follow the state food code, and having something separate in one county can be confusing for the businesses.
So, that's not unprecedented. A lot of counties have different regulations. So, I guess with all the respect to the other counties, my concern is Anne Arundel County. And I want to make sure that the businesses in Anne Arundel County are able to do it. But again, those products that they're reselling, they don't have to wash, they don't have to clean. They're just taking them from the vendor, putting them in the fridge, selling them. So there's what's the need? And I think the reason for this bill is specifically to gives the health department the flexibility to treat each business on a case-by-case basis. So it might apply if you're manufacturing or if you're preparing the product locally or on site, but those items are already gone through the process and they're just only being retail. They're not being manufactured or prepared on site.
At this particular facility, there was some processing that was being done on site and products being broken down and repackaged. So that's the concern with not being able to wash your hands, as well as, we want to make sure that everything is in temperature. We know nothing about the refrigeration units that are at this site. And again, doing stuff for food service facilities, even if they are open air market on a case-by-case basis, makes the standards very, very inconsistent.
Thank you. Thank you, Madam Chairman.
My pleasure, Delegate. We have Delegate Chisholm, followed by Delegate Shalega.
Thank you, Madam Chair. And I know we've passed quite a few cottage food industry bills, and I know this isn't exactly the same, but to my understanding, some of these open air markets were already operating and they've been shut down by the Anne Arundel County Department of Health once they were realized. But my question is, because you mentioned it, do we know of any incidences at all coming out of any of these open air markets before they were outlawed of contamination or illness developing from them operating on a normal basis?
Again, the term open air market is not defined, but basically, if we're talking about food stands or farm stands, none of them have been shut down. We just required this one not to sell or potentially hazardous food. They can sell produce, they can sell properly labeled cottage foods. In this particular instance, they had moved in refrigeration and freezer units and were selling potentially hazardous foods beyond their produce and their cottage foods. So we have not shut down any quote unquote open air markets or farm stands.
Thank you, Madam Chair.
Thank you, Delegate Chisholm. Next, we have Delegate Shalega, followed by Delegate Johnson.
Thank you, Madam Chair. Don, can you envision having some kind of waiver program? Can you think of a way to allow this to go forward? It's clearly not a 7-day-a-week business. They use disposable utensils. We're asking you to think outside the box to create an atmosphere where this can go forward, where you still have control over what's going on. Obviously, you care about food safety and people not getting sick. So, what can you tell us about that?
My concern, my biggest concern with this is setting up some sort of standards where potentially hazardous food is on site and never being able to wash your hands or any surfaces because there's no water to this facility. That is a huge risk when it comes to food safety. As if we have learned anything over the last couple of years during the pandemic, we know that washing hands is the best way to keep from having contamination. There's no way at some of these open air markets to be able to wash hands, utensils, or anything.
But they aren't, what if they didn't consume on site? So, obviously the vendors could, bring water, bring hand sanitizer, I'm not trying to, I'm just asking you to consider waivers, obviously this is a program, this is an open air market, whatever we want to call it, that's very, very popular with the residents of Anne Arundel County. I've been there, my mom lives close by. And, I think we need to figure out a way to make this work instead of just have you say, no, 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 no.
The concern is with the possibility of cross-contamination. And it's not that we're saying no, no, no. We do have a food code that already has stuff in place. And if this place wanted to try to do something that's a little out of the box, we would have been more than willing to work with them. Unfortunately, we issued them an order of abatement. And instead of coming to us and trying to address any of these issues, they just continued to put potentially hazardous food in there that every time we went back, we had to have them remove. And it's just, with no water and the ability to wash hands, without us inspecting on a regular basis, we really don't know what's happening with the possibility of cross-contamination of the food product.
Thank you. I understand your concerns and I hope we can figure this out together. We're all smart people.
Delegate Johnson, followed by Delegate Robin Lewis.
Thank you, Madam Chair, and thank you, Don. And we all understand your concerns about public safety because we share those when we consider bills and putting things into law. You seem to keep referencing this one vendor, where we're talking about many vendors. So with this left in at your discretion to set this up, is there not some way that you could specify that it is only prepackaged foods that were made in health department approved kitchens? I mean, that seems to be what Delegate Saab's talking about, just retailing products. So giving you control on setting that up, is there no way that you could set up a program to make sure that that is what's happening?
Again, it's difficult to do one in one county, and that this bill actually waives the food regulations. So that's the concern, is waiving the food code is what makes this so dangerous.
So again, there's nothing that you could set up to make sure that it's only the prepackaged foods made in health department approved kitchens.
Again, if we don't have a license and they're waived to the food license, we have no authority to inspect on a regular basis to know whether the refrigeration units are working properly or not.
Madam Chair, if I could just do a little follow-up.
Okay, I'm going to go ahead and allow it, Delegate Johnson, because you don't ask many questions, okay?
Thank you, Madam Chair. So is there any way, Don, that you could come up with a specific license for what we're asking? And that way you have something to reinforce the rules by pulling that license.
The only way we could create a license, again, the licenses are, this is a state code. And then in our county code, we have licenses, and we don't have a definition of an open air market or a license for such a thing. So we would have to go to our administration and to our county council if we were to create such a thing.
Okay, thank you, Don. Thank you, Madam Chair.
My pleasure. Delegate Lewis, followed by Delegate Hill, followed by Delegate Morgan.
Thank you, Madam Chair. Thank you, Delegate Saab, for continuing to try to find a solution to this conundrum. I'm curious for the gentleman, and I can't see your picture now, so I can't see your name. If you would help us understand a little bit better what the obstacle really is. I'm familiar with farmers markets where food is sold in different forms, prepared food, hot food cooked right in front of you, deli items that are wrapped and you can take home, like homemade cheeses and pickles and things like that. And I'm just wondering, and these are in open air places and parking lots, typically, where food is sold, where people eat and take food home, and somehow or other, it's possible. So I'm just trying to understand, what is the statute that allows farmers markets to operate that doesn't apply to the type of setting that Delegate Saab is referring to?
If it's a farmer's market just selling produce, there is no food being served there, then they don't need a food license. If they are serving some of the items that you are spoken about, they would need a food license to prepare hot foods and serve it to the public.
Thank you. So there are hot foods that are sold. There are also cold foods that are sold. There's cheese and there are pickles that are being sold. Those also require a food license to sell?
Yeah, any of the cold product also needs a food license because it has to be kept at a proper temperature, and that's what the license and the inspection process verifies.
And if I may, Madam Chair, this is what I also don't understand. One of the biggest farmers markets in the entire state of Maryland is right here in my district. It's in a parking lot under a highway overpass, and there's no running water there. So hot food is sold, cold food is sold. People sit down at picnic tables, they eat sandwiches. And there's no sinks that I'm aware of. There must be some provisions for, obviously, basic sanitation, but if we can do it under a highway overpass in a parking lot, how is it, what's the obstacle for this setting that Delegate Saab is referring to?
I'm not sure what farmers market you're talking about.
It's the biggest farmers market in Maryland.
It's the one in Baltimore City. Yeah.
It's the JFX. We call it the JFX market.
Yeah. I don't know if they have temporary water facilities that at those stations. Some people put temporary water stations where they can wash their hands and their utensils, because if they're preparing hot foods, they have to be able somewhere to be able to wash their hands and all their utensils.
Thank you.
Okay.
Thank you, Madam Chair.
Thank you. We have a lot of bills. I've been very flexible. So let's keep that in mind. Delegate Hill, followed by Delegate Morgan.
Okay, thank you very much. Thank you for the bill. Thank you for being here to testify and explain for us today. Can you just tell us, when was the last time that you all reviewed your standards for open air markets and food service to see if, to update them? And if there's any plan to do so. Again, we have bills on this every year. It's a big problem.
That is the state code, and that gets reviewed by MDH, and I do not know when they last reviewed that to see whether they would address open air markets as a separate entity.
And a follow-up, so do you all treat open air markets like a unique entity, or you just gather them under the closest cousin?
Again, if we're talking about farmers markets where they're selling produce, the health department doesn't have any regulatory authority over it as long as they're not selling potentially hazardous foods. They can sell cottage foods, they can sell the produce, but they would not need a license, and the health department would have no jurisdiction over a farm stand or a farmer's market.
My question was, do you group these open air markets? I mean, they don't have a unique category. So how do you decide what entity that is defined you're going to group them under?
The only way we would define them is if they're selling potentially hazardous foods, and then they would need a license, and then we would regulate them, license them, and inspect them on a regular basis. Anything less than that, that does not have potentially hazardous food, the health department doesn't have a criteria or anything to do with them because there's no license involved.
All right, thank you.
Thank you. Delegate Morgan, followed by Delegate Bagno.
Thank you, Madam Chair.
My pleasure.
My question is for Mr. Curtin. Isn't this kind of reason why we need the bill? I'm sensing a lot of different questions coming from my colleagues here. There seems to be a lot of confusion about what the open air market is versus a farmer's market, what you can and cannot sell. But isn't that the reason for the bill, that it sets up a universal standard, allow these counties to implement some of this stuff?
Again, the food code already addresses this. If you want to sell potentially hazardous food, there's a licensing requirement. You meet all those requirements, and then there can be inspections done on a regular basis to make sure that it is operated in a safe fashion.
Quick follow-up, Madam Chair. Just help me understand, what is potentially hazardous food?
That is foods that have to be held at a cold or hot temperature so that they don't grow any bacteria or foodborne pathogens. And so basically meats, fish, and dairy products, anything that has to be kept cold, or if you're preparing foods in a hot fashion.
Okay, thank you. Thank you for the questions. Thank you, Madam Chair.
My pleasure, Delegate Morgan. Delegate Bagno.
Thank you, Madam Chair. And I think the number of questions speaks to the committee's commitment to find a solution. So my question for you, Mr. Curtin, is thinking outside of the box, could we look at the definition of sinks and flooring? Because you did mention in your previous testimony that some facilities operate like a temporary sink. And I'm wondering if maybe looking at how we define these requirements in the food code, if we could broaden the definition of what those look like, we might get a little closer to solving this problem.
Again, under the food code, that would be with MDH and the food code so that it would be standard across the state. Again, it's very difficult and becomes very confusing when you have one criteria in one jurisdiction, but 23 others are doing something different. We constantly get questioned or criticized because one county is doing something different than another. And for the industry, they would like to have things very standard.
I appreciate that. Thank you very much, Madam Chair.
My pleasure. Any further questions from the committee on this panel? Okay, seeing none. There's a favorable, but is actually Mr. William Love, but I understand that person is not here, right? All right, so this actually concludes the bill hearing on House Bill 1193. Thank you very much for being with us today. Next, we have House Bill 1222, Delegate OBrien, Public Health, Baltimore City Behavioral Health Crisis Incident Review Team. And we do have the judiciary assigned to this bill. So I don't have a name, but I know the judiciary, this is jointly assigned. Delegate OBrien, you have 5 minutes. Good afternoon.
Good afternoon. Thank you so much, Madam Chair, and my colleagues in the Health and Government Operations Committee. It seems to be my home away from home this session. I'm going to be as quick as possible here. I want to cede the rest of my time to one of the members of Mayor Scott's staff. So for the record, Delegate Marlon Amprey here on behalf of House Bill 1222. Baltimore City Behavioral Health Crisis and Incident Review Team. This is a local bill. It's being introduced to establish the Baltimore City Behavioral Health Crisis Incident Review Team to examine behavioral health crises that involve interaction with law enforcement in Baltimore City and recommend and facilitate changes to minimize the need for law enforcement involvement in behavioral health crises, providing that meeting of the review team are closed to the public and not subject to the Open Meeting Acts when discussing individual behavioral health crises or incidents. These behavioral health crises incident reviews will serve to inform continuous improvement in service delivery by reviewing the system and identifying trends and gaps in systems of care, and will establish recommendations and implement change as necessary to improve crisis care experience. This legislation would allow for sharing of necessary data amongst the entities named in order to promptly and effectively identify where a resident was not served or not adequately served, resulting in police involvement in crisis intervention, and how such encounters can be avoided in the future. I'm very happy to bring this bill on behalf of the Scott administration as we are working to rethink and reimagine public safety here in Baltimore. And I want to make sure that we're always thinking about how we can ensure that the best people are brought forward to deal with incidents that happen, and that we can work our hardest to ensure that police are coming only when needed in the event that the rest of the public safety is in danger. I want to ensure that I give enough time to Ms. Natasha Mehu, who is here and testifying in support of the bill. So with that said, I ask for a favorable report for the committee, and I want to give the rest of my time to Ms. Natasha Mehu, who was here on behalf of Mayor Brandon Scott's staff.
Thank you, Delegate Humphrey. Ms. Natasha Mehu, you have his 3 minutes plus your 2 minutes, a total of 5. Will you please get started? Thank you.
Thank you, Madam Chair, members of the committee. Natasha Mehu here on behalf of the Mayor Scott administration in support of House Bill 1222. So I do want to thank Delegate Humphrey for putting this bill in on behalf of the administration. Unfortunately, police encounters with people in behavioral health crises far too frequently result in a use of force or other involvement with law enforcement that then has the individual involved in the criminal justice system. This could result in serious injuries or other adverse outcomes that at times point to systematic errors and present learning opportunities for all stakeholders to ensure that we could better improve the delivery of services to our residents. In April 2017, the city of Baltimore entered into a consent decree with the U.S. Department of Justice. And as part of that consent decree, the city agreed to conduct an assessment to identify gaps in behavioral health service systems, recommend solutions, and assist with the implementation of recommendations as appropriate. So House Bill 1222 is a result of that assessment. It is clear to us that the status quo solutions for policing, public safety, and addressing the needs of those experiencing behavioral health crises simply aren't providing the best outcomes for our residents. While some of the responses to police response to individuals having these crises result in injuries or other adverse outcomes, many do not. However, while they do not result in serious injuries or adverse outcomes, they still may be traumatizing to the individual who has experienced them and may reinforce negative stereotypes about people with behavioral disabilities. And so they also represent an unnecessary draw on police resources. So there's certainly an urgency here that this moment demands of coordination between different agencies and our local partners to ensure that we are doing the best that we can to improve the delivery of services, divert those who are suffering from behavioral crises from the criminal justice system. So House Bill 1222 establishes the Baltimore City Behavioral Health Crisis Incident Review Team to examine behavioral health crises that involve interactions with law enforcement in Baltimore City. The review team will recommend and assist with procedural, logistical, and clinical changes in order to maximize the need for law enforcement during minimize the need for law enforcement during behavioral health crises. So it's critical that these review teams include participation of key decision makers within the city's public behavioral health system so that we can promptly identify where an individual has not adequately been served and how such encounters can be avoided in the future. And so with that, we request a favorable report on House Bill 1222. Thank you.
Are there any questions for this panel of favorable? Okay. Chairman Pendergrass.
Thank you, Madam Chairman.
Sure.
I'm a little confused by the bill. The bill seems basically to set up something for the city government to do. And I'm wondering why a bill is necessary to do this. And I'm sure that I'm missing something. So maybe Ms. Mehu could explain to me why the city isn't just choosing to do it and needs us to pass a bill.
So it is our understanding that in order to do some of this data sharing with our behavioral health entities that aren't necessarily members of city government, we do need to have the authority to share that information with them. And that's why we're putting forth this bill, and why it's Baltimore City specific for the review team is also because of the consent decree that we needed to create something particular for Baltimore City.
So my question would be, would a bill that specifically required the state departments named, and you could name them, to cooperate and provide data be the bill to be passing? This just seems convoluted to me. And also I noticed that it doesn't seem to be a delegation bill. It seems to be a delegate's bill. And if it's something for the city, I would think it would be a delegation bill. So that too has me puzzled.
The bill was heard by the Baltimore City delegation on this past Friday. So my understanding is it is a delegation bill. Delegate Ampry is sponsoring it on behalf of the administration.
Okay, that helps me. Okay, so maybe if you could just circle back on this to see if this is the best way to accomplish what you're trying to accomplish. And I'm not saying that it's not, it may be. This is a laudable goal and it probably needs to be done, but we just want to get it right.
Completely understand. Thank you.
Thank you, Chairman Pendergrass. Any other questions from the committee members for this panel? Seeing none. Oh, I have Delegate Hill. I almost missed you, Delegate Hill.
No, just real quick, I'm just going to ask Delegate Ampry, just following up on the chairman's question. Are you going to be getting a delegation letter?
Yeah. I'm sorry. I think you asked for a delegation letter. Is that what you're asking?
Yes.
Yeah. So we didn't want to take too much time on Friday, so we had our meeting, but I believe that we should be voting sometime this week, and the bill was received well. I expect a full support from the delegation. As soon as that letter is made available, we'll shoot it right over to the committee.
Thank you very much. Seeing no other questions, we now have a witness that is favorable with amendment, and that is Adrienne Bridenstine from the Behavioral Health System, Baltimore. Good afternoon.
Good afternoon. Thank you, members of the committee. I'm Adrienne Bridenstine. I'm with Behavioral Health System, Baltimore. You have a copy of our testimony in your packet, which includes our written amendment. It's really a technical amendment that we're requesting to this legislation, but we are supportive of it. We have BHSB is the local behavioral health authority in Baltimore City. So in that role, we oversee that full range of mental health and substance use services. And for the purposes of this bill, we would be that entity that would be sharing that state level data that you were just having a conversation about, which is data that is technically owned by the state, but the local authorities have some authority over and use to make system level decisions, and also use for other types of collaborative review processes like overdose fatality review, child fatality review processes. All of those types of processes have been established in state statute. So that's part of the reason we're working with the administration to move this bill forward. So we just, again, request a minor technical amendment, which would change the language to list Baltimore City's local behavioral health authority rather than BHSB in statute, and urge a favorable report.
Thank you for your testimony today. Are there any questions for this witness? Seeing none, thank you so much for being with us today. And this concludes the bill hearing on House Bill 1222. Next, we have House Bill 1185, Delegate Patterson, Public Health Sickle Cell Disease Referral for Transcranial Doppler Ultrasound. Good afternoon, Delegate Patterson. You have 5 minutes.
Good afternoon. Good afternoon. Chair Pendergrass, Vice Chair Pina Melnick, and committee members of House Government Operations. I'm Delegate Edith Patterson, and I'm here to present House Bill 1185, which is a request for sickle cell disease referral for transcranial Doppler ultrasounds. Sickle cell disease, here from this point known as SCD, is one of the world's foremost potentially lethal genetic diseases that has severe physical, psychological, and social consequences for those affected and their families. And although it can be treated, there is no early easy cure for this crippling disease. So lifelong care to prevent or treat problems from SCD is really critical. Data shows that it occurs among approximately 1 out of every 767 births in Maryland and 1 out of every 256 African-American births in Maryland. The estimated number of patients in Maryland include around 2,800 plus adults and 1,900 plus children or pediatrics, with a total of around 4,800 sickle cell disease patients. Why is there a need for this legislation? Well, transcranial Doppler ultrasound, TCD, is a test that uses sound waves to see inside of the body. And this test shows how fast blood flows through the blood vessels in a child's brain. Children with SCD are at a higher risk for strokes. And the risk is highest in children with elevated blood flow velocity in the distal, internal, carotid, or proximal middle cerebral artery, as measured with transcranial Doppler ultrasonography. This is a report from the NIH study. Maryland current law requires screening is provided for all newborns, but not this specific type of screening. Therefore, this test is really needed. House Bill 1185 requires then a physician or an advanced practice nurse, except under certain circumstances, to refer certain minor patients who the physician or advanced practice nurse knows to have sickle cell disease to a hematologist who specializes in sickle cell disease for a transcranial Doppler ultrasound. And this requirement is at least once a year for these patients. This legislation will specify those who are at least 2 years old and under the age of 17 and whom the physician or advanced practice nurse knows to have sickle cell disease be referred. And I'd like to acknowledge the advocacy of Rudy Williams, who's president of the Association for the Prevention of Sickle Cell Anemia from Hartford, Cecil, and Eastern Shore, and also James Thornton, the president of the Hartford County Association for the African American Leaders. Madam Chair, I am requesting a favorable report for this proposed legislation. Thank you.
Thank you so much for your testimony on House Bill 1185, Delegate Patterson. We have actually no other witnesses on your panel. I'm going to open it up now for the committee. Are there any questions from the committee members? Okay, seeing none, we do have an unfavorable. Ms. PAM Casemeyer, good afternoon. You have 2 minutes.
Hello, members of the committee. PAM Casemeyer here on behalf of the Maryland chapter of the American Association of Pediatrics and also the State Medical Society in respectful opposition to this bill. We'd like to commend Delegate Patterson for her commitment to addressing sickle cell disease and disorders. It is a very challenging health disease that does require some additional attention. You'll hear me on her next bill in support because we find the next bill to be a good platform. The reason we're here really is, as you have heard from us on other pieces of legislation, we have a lot of concerns in opposition to legislating specific medical care practices. As you all have known, it's very difficult to legislate standard of care because it constantly changes, and then you have to try to keep it up to date, and it doesn't always apply in every single circumstance. So this bill is of concern to us as opposed to the one you'll hear from me next time, on the other side, really just legislates what a provider has to do for a specific kind of test. We think legislating that standard of care is really counterproductive and actually could eventually work to create unintended consequences that were well intended initially. So with that, we would request an unfavorable report.
Thank you for your testimony today. Are there any questions from the committee? I see Delegate Kaiser. Delegate Kaiser.
Thank you, Madam Chair, and thank you, Delegate Patterson, for bringing this bill. It's good to see you today. My question is actually for Ms. Casemeyer. I understand your concern about legislating a standard operating procedure, but is Delegate Patterson on the right track in that not enough people end up getting this TCD? If I remember the acronym correctly, that probably could use it?
I don't know. I don't know that that is the case. There is automatic newborn screening. I understand this is actually an ultrasound, not a screening test, that they are screened initially during the newborn screening. You all just passed legislation this year that would update our newborn screening panel to stay consistent with federal requirements. I don't know, and I could get back to you on whether the standard of care is every single patient with this should have this ultrasound or not. The discussion around this when they were reviewing it was there isn't always a one-size-fits-all answer. This doesn't even differentiate whether someone's already been identified with sickle cell. This just says everybody needs it once a year from a hematologist. So I think there was a bit of a concern that we're becoming overly prescriptive in statute, especially even if it was the case now, if 6 months from now, they have a different kind of screening exam or something that's become more effective, then you've got an outdated statute that requires providers to do certain specific things. I don't know if that helps answer your question.
Yeah, that partly answered it, I believe. But a follow-up, Madam Chair?
Absolutely.
Thank you. Well, I thought I read in the fiscal note that this actually is only for people who've been identified with SCD. And I see Dr. Hill nodding. But my follow-up question is, if it's not this test, do you have any other creative thoughts about helping people who've been identified with having sickle cell disease, but are seemingly not getting proper treatment? Do you have any reason to believe that's the case?
Actually, Delegate Patterson's next bill, you're going to hear us talk about. We think it's a really great approach. There's a couple other pieces of legislation today too. I'm not talking on all of them. You don't need to hear me talk too much. But I think that there's other approaches. It is definitely something that needs some additional attention. It is a challenging disease to manage and to make sure people get the services they need. We're just not comfortable being this prescriptive in what's required to be done and what referrals are to be made. So we're really looking forward to talking about the other kinds of approaches that have been identified.
Thank you. We have Delegate Collison followed by Delegate Hill.
Thank you, Madam Chair. At the risk of continuing to beat that horse, I'm wondering, Pam, if there's a way, if there's information that you could give us around how often this test is used with respect to this population of children. Are we using it? And I understand, and I'm, the issues that you've raised and appreciate them. I'm just wondering now, how often do we do this? Do our physicians do this? And is it a test in following up to Delegate Kaiser's question that we're using to its maximum advantage, I guess is my question.
And I will try to gather that information. I will tell you the person who reviewed these bills for us, in addition to others that are working in this space, was an internal medicine physician who was the president of the National Sickle Cell Disease Foundation Association and head of the National AMA for a number of years, whose family has had this disease, and that's really been a huge focus for her. And she was very concerned about the legislating the protocol and timeliness in the statute per se, but I will try to get you that information on how well it's used, but it did come from sickle cell disease professionals who were a bit concerned about this, not the other bill we're about to talk to and some other initiatives.
Right.
So, but let me see what I can gather, and I will get back to you.
Okay.
And I might have this doctor reach out as well, because she's really nationally expert on many of these issues.
Thank you. Thank you very much. Thank you, Madam Chair.
My pleasure. Delegate Hill. Delegate Hill, you're muted.
Thank you. I'm sorry. I was trying to unmute.
It's okay.
So I guess this is a question for both. I know that normally we do the pro panelists first, but since the delegate is still here, I'm looking up and I'm seeing numbers that say that 10 to 20% of sickle cell disease children get pediatric strokes, and that sickle cell disease children make up 25% of all pediatric stroke victims. So this seems like a pretty big deal, and maybe we'll see it in the next bill. And I guess the question, Pam, for you is, if at all possible, the expert who has the data and the numbers, in addition to you, when we see this in subcommittee, I just think it would be really helpful to be able to have this discussion with that expert or someone else, if that's at all. I know people have busy schedules.
And I certainly will. I'll see. Her name's Dr. Willarda Edwards. I will.
Hey, I know Willarda. Okay.
Yeah, so I think it's generally, you've heard from us before, so I don't want to overspeak just for this particular requirement. There's definitely a recognition that we have to up the access to care and identification of sources. I think it's a more generic, no pun intended, concern by the medical community that this, if you put in law this year that a hematologist has to refer within every year, within the year, whatever.
A pediatrician has to refer a sickle cell patient annually to be assessed.
And then 6 or 9 months from now, there's a different test or a different procedure that's more effective. We have this outdated clinical requirement in the bill that we then have to come in and pass a new bill to fix that requirement. And it's because the statute's now outdated, and we've had this with a number of different issues over the year. So that was really as much, not even the fact that we don't need to get more kids tested or anything like that, but just we've really tried to not legislate specific medical care in the statute because of ever-changing standards of care and concern that our statute won't stay current with what the medical professionals are finding most effective.
Okay, well, thank you, Madam Chair. Thank you. I'll take a look at our mammogram statutes, and I'll give Dr. Edwards a call. I'll try to give her a call too.
Thank you so much. Any other questions? Seeing none, this concludes the bill hearing on House Bill 1185. We're going to go to House Bill 1243, Delegate Howard.
Thank you, Madam Chair. Colleagues, great to see you this afternoon. Delegate Seth Howard here on behalf of HB 1243. This bill establishes a rural non-emergency medical transportation program, or NEMT, for hospitals to coordinate transportation by a nonprofit organization to or from medical services for eligible individuals. The program may not provide transportation to an eligible individual for more than 120 days at a time, or to an individual who requests but does not use the provided transportation on more than one occasion. If a hospital enters into a contract with a nonprofit organization, the hospital must report the name and contact information of the nonprofit organization to the Maryland Department of Health within 30 days after the contract is signed. It's an annual budget bill of appropriation of $1 million for MDH to administer. And with that, I would ask for a favorable report. And I would also, I know I've got several folks here on the panel, and if I could cede some of my time, Madam Chair, to John Hartline. He is the chair of the Rural Maryland Council, and essentially, as I was a panelist there about 2 months ago, is the nexus of this bill through some discussions and conversations I've had with him. So if that's okay with you, Madam Chair, if I could do that.
That sounds great, Delegate
Thank you.
Howard, and we'll do that. So, sir, Mr. Hartline from the Tri-County Council for Southern Maryland, will you be so kind and get started? You have the delegates 3 minutes and 53 seconds left, plus your 2 minutes. Good afternoon.
Good afternoon. Thank you, Chair. I'm John Hartline, the Executive Director of Tri-County Council for Southern Maryland and the Chair of the Rural Maryland Council. Rural non-emergency health transportation has always been a problem. The hospitals must be in high-density areas, and the people in the rural areas are expected to go to the cities for specialized care. Today's specialized care often requires specialized follow-up, and that means the patient must go back multiple times to urban areas for follow-up doctor's visits and tests. Our council's been working on the problem since 2017 in partnership with the Community Transportation Association of America. We now have a working system with hospital care coordinators selecting the patients based on medical condition and need and transportation need. We have the transportation being provided by human services transportation providers who are well-trained in caring people. This has resulted in a 98% follow-up visit success rate. Finally, we have the statistics to show that the system saves the hospitals money far more than it costs. I want to draw your attention in my testimony. There's a graph on the last page of my testimony where Calvert Health was able to extract pre and post enrollment medical cost information from the CRISP system. The information shows that the Wheels to Wellness program reduced medical costs by approximately 57%. I'm asking for a favorable report to allow the rural areas of the state to save healthcare system money and to produce better health outcomes by reducing transportation challenges in the rural areas of Maryland. And that concludes my testimony.
Thank you for being with us today and for the work you do. Next, we have Ms. Noelle Flaherty.
Hi.
Good afternoon.
Good afternoon. My name is Noelle Flaherty. I am a Director of Case Management at Calvert Health, I'm a registered nurse, and I am one of those hospital care coordinators that is mentioned in this bill. Jim talked about the cost savings, which is significant, but I wanted to also talk about the human element and the human savings and benefit to our community members. So we work with our local health department, with the ARC of Southern Maryland, with primary care providers and others to identify patients for this important transportation program. And we've seen some real benefits in the community. I'm going to give you an example, and I have more if anybody is interested. So we had a patient who was a new dialysis patient, needed to go to dialysis Monday, Wednesday, Friday, not eligible for Medicaid transport for a variety of reasons. The health department reached out to us to see if we could get this individual in for transportation. Her daughter had a car but had to work and was going to have to quit her job if she was going to take her mom to dialysis. And so we were able to coordinate our schedule so that we can transport this person. Daughter's able to keep her job and patient's getting the care that she needs. Similarly, we had a gentleman who was elderly and living alone, previously independent, previously able to drive his car. The doctor wanted him to come in for an appointment. He didn't have transport. The ARC of Southern Maryland was able to provide door-to-door service for this gentleman and get him to his doctor's appointment. We did not have to have an emergency room visit, which is what we would have had otherwise. And the patient got his needed care. So there's just a lot of community benefit to this type of program, and I hope you will consider it as well. Thank you.
Thank you for your testimony, and thank you for being a nurse. Now we're going to open it up for questions. Are there any questions from the committee? I see Delegate Robin Lewis.
Thank you, Madam Chair. I'd like to thank the bill sponsor so much for bringing this bill. I think it's fantastic. It really demonstrates the links between access to transportation and health outcomes. So thank you. And also to your panelists. My question for whoever is best to answer is, does the bill provide, or rather propose, measuring the change in health outcomes if the bill were to pass? I'm thinking specifically about the requirement under the total cost of care that hospitals demonstrate, measure and demonstrate improvement in overall health outcomes. So will the bill allow us to learn more about that and allow hospitals to do that better?
This is John Hartline. It's not a requirement of the bill, but that's certainly not something we would object to. We're currently working with 3 hospitals, St. Mary's MedStar, Calvert Health, and the University of Maryland Medical System in Charles, in La Plata. And we intend to, if we get funding, to carry people from the rural areas probably into Prince George's County and into Anne Arundel County. So it would be very useful to measure our outcomes and make sure that it's resulting in reduced costs.
Thank you, sir. Thank you.
All right, and sorry, I can add on to that if that's
You
okay.
You
Oh, sorry.
cannot, because we're only allowed one witness to
I
answer the
apologize.
question. But you can send us the information, offline, or maybe a member will ask you a question, okay? Next, we have Delegate Collison.
Thank you, Madam Chair. Unfortunately, I have another question, which is I'm not sure, is the contract between a nonprofit and the hospitals only? Or is it between like maybe county government and the nonprofit? So for example, in the case of the person who needed to go to dialysis, that wouldn't necessarily be happening in a hospital. So I'm just wondering how to get the maximum benefit out of the program, where the contract is.
Who's the best person, Delegate Howard, that can answer that question? One person.
Mr.
Noel,
Hartline.
go ahead and take that.
Or Noel.
Okay. Mr. Hartline? Okay, Noel?
Sorry, our current model is that the Tri-County Council manages the contracts, and that is working very well for our Wheels to Wellness program. So the hospital identifies the patients, and we work with the ARC to schedule, and the Tri-County Council manages all the back end information. And that, like I said, that's worked very well for our program.
May I follow up, Madam Chair?
Yes.
Do you envision then, Ms. Flaherty, that the patient doesn't always have to come from the hospital, but could be identified by a practitioner, a primary care doctor?
Yes, absolutely. So in our current model, some patients are identified by the hospital, but many patients are identified out in the community, and we help to facilitate with that. So the health department will call us, or the primary care also has case managers. They'll call us, and we help to connect with resources. So it's really, in our county, it is a shared responsibility to help get patients connected with their needed care outpatient. And we are expected as part of total cost of care to provide those outpatient services as well.
Okay, great. Thank you. Thank you, Madam
My
Chair.
pleasure. Chairman Pendergrass, followed by Delegate Kaiser.
Thank you, Madam Chair. I am glad you mentioned the total cost of care waiver because that's where I'm stuck. This is a service that I would expect to occur through that waiver because it would be intended to keep the cost of care down. So I'm very puzzled why we would need a program involving $1 million from the state when this seems to be exactly the goal of that waiver. And I would think that the entities involved would be doing this so that that patient wouldn't be hospitalized or wouldn't go to the emergency room. Can you explain why the total cost of care waiver doesn't solve your problem? Anyone who wants to answer it.
Mr. Hartline.
I'll take that then. We set up the system with the original objective being that we would solve a transportation problem and reduce cost. We've had discussions with the Blue Cross Blue Shield Foundation in giving us funding. They diverted all of their funding to COVID. We've talked to people in the cost containment at the state level. They were looking at it. At this point in time, since Seth Howard was willing to put in a bill, we put in a bill to help the rural areas. It's definitely a cost containment issue, but we didn't want to wait 2 or 3 years while they made up their mind. So we were moving forward with Rural Maryland Council funds to prove that it saved money. Does that answer your question?
Yeah, thank you. And thank you, Madam Chair.
My pleasure, Chairman. We have next Delegate Kaiser, followed by Delegate Saab.
Thank you, Madam Chair. I know that Ms. Flaherty answered somebody else's question a couple minutes ago, but a few minutes before that, she was trying to answer a question and I wanted to hear her added commentary on that issue.
I think it was about total cost of care. So we did answer it. Thank you.
We're a very kind committee. We really are. We're the best. Next, and I am so biased. Next, we have Delegate Saab.
Thank you, Madam Chairman. Actually, Delegate Carlson asked a couple of my questions, which is great. Thank you, Delegate. But the question is, I guess, for the sponsor or anyone else, the fiscal note, is this what is currently being spent? How'd you come up with $1 million fiscal note?
I can answer that. We're currently, we've used funding from the RMC. That's kind of what you call formula funds that the governor has provided. And we've been spending about $80,000 a year for the 2 counties. We wanted to take it to the next level. I had been in contact with the Lower Shore Regional Council, the Mid Shore Regional Council, the Upper Shore Regional Council, and they all were interested and excited. They do their own transportation. We're the only Tri-County Council that really just works with nonprofits. But we wanted to take it statewide because the savings were so dramatic.
Thank you. Appreciate the answer. Thank you, Madam Chairman.
My pleasure, Delegate. So seeing all the questions on House Bill 1243, this concludes the bill hearing on House Bill 1243. Thank you for being with us today.
Thank you. Thank you, colleagues.
Our pleasure. We have next Delegate Patterson, House Bill 1188, Public Health Sickle Cell Disease and Trade Information for Individuals and Healthcare Practitioners. Delegate Patterson, good afternoon again.
Good afternoon once more. Good afternoon, Chairman Pendergrass, Vice Chair Pina Melnick, and members of Health Government Operations. I'm very delighted and honored to present House Bill 1188. there are quite a number of sickle cell bills because there is such a great need for this, for cure and for recognition and treatment of this debilitating disease. I have worked with the advocates as well as with those who are part of the healthcare system to work on a viable piece of legislation that would require the Maryland Department of Health to establish and implement a system of providing information on the sickle cell trait or on thalassemia trait. And this was new for me because I wasn't aware of it, but it's a group of hereditary diseases caused by faulty hemoglobin synthesis. And this thalassemia or these diseases are found primarily in Mediterranean, African, and Asian companies. And so as we branch or move forward, it's really critical that we expand that information. House Bill 1188 will require that information for individuals and healthcare practitioners work with the Maryland Department of Health to establish and implement a system of providing information on the sickle cell trait or thalassemia trait to individuals diagnosed with sickle cell disease or sickle cell trait to the individual families. And this is really important because oftentimes they're unfamiliar with what is actually going on. And even though there might be some information that's there, we feel that there are other resources and ways in which we can get this information out. The bill requires the department to maintain on its website a certain list of resources for healthcare practitioners and a plan for updating its website to meet certain requirements. And again, these are specialized services. It's been my pleasure to work with regarding MedChi and its amendment to this legislation. And I'd like to thank the sickle cell disease advocates and for the testimony of those who are impacted by this disabling disease. Therefore, I'm seeking a favorable report proposed for House Bill 1188. Thank you, Madam Chair.
Thank you so much for your testimony. Next we have, actually, I'm going to go, since you work with her, I will call PAM Casemeyer. She's favorable with the amendment, and then we'll open it up for questions, okay? Ms. Casemeyer.
Hello, members of the committee, Pam Casemeyer, and again, want to call out Delegate Patterson for her commitment to looking at this issue, which, despite my previous testimony, is definitely an area where we need to increase both public awareness and healthcare provider awareness of resources, services, those kinds of things. This bill really would create an ability to pull together really relevant information that could be shared with both patients and providers. It is understand being posted on the website. Sometimes people think that is good, sometimes it's not, but it really becomes a good focus of information. And there are other ways you can get it out, but this begins to require that it gets pulled together, regularly updated, that it's pulled together with the input from healthcare providers, stakeholders, families, advocacy groups, whatever, so that both the provider community and the families themselves can know where to find resources and what they should be looking for. Because a lot of the challenges with sickle cell is as much education and understanding where to go and what you need as it is anything else. And it is a very challenging disease to manage. Our one amendment that Delegate Patterson referenced is there was a requirement in the bill, or is a requirement in the bill, that licensure people put on the provider's licensure renewal application a reference to this on the website. We're concerned that you're not going to want to start adding a lot of things to a licensure renewal application, that there's better ways to get the information out. So we don't think that provision works, but we're really looking forward to working with her and you and trying to move this forward to increase awareness and effectiveness of information.
Are there any questions for Pam, for Ms. Casemeyer, or for the delegate? Okay, seeing none, this will conclude the bill hearing on House Bill 1188. And Delegate Patterson, you have House Bill 1192, the Maryland Healthcare Commission Studies of Issues Affecting Individuals with Sickle Cell Disease. Good afternoon again. You're muted, Delegate. Delegate, you're muted.
Thank you. Good afternoon, Madam Chair. And this is my last bill regarding sickle cell for the session. Good afternoon, and Chair Pendergrass, Vice Chair Pena-Melnick, and members of Health Government Operations. I am Delegate Edith Patterson, and I'm very honored to introduce House Bill 1192, Maryland Healthcare Commission Studies of Issues Affecting Individuals with SCD. This is a very important bill because according to a report, as you've heard before, there are over 4,800 Marylanders that are affected. This disease is estimated to affect 85% of African Americans, 15% of Hispanic origin, and approximately 100,000 individuals each year. The bill will require a closer look into what the healthcare needs are for those living with SCD, the barriers to care that exist, and would shed light on opportunities to benefit from healthcare the SCD patients receive. This bill would require the Maryland Healthcare Commission, in consultation with the Maryland Department of Health and certain experts and stakeholders, to conduct a study on the existing level of SCD education among those who provide emergency room medical services, the coordination of healthcare service for those who are transitioning from pediatric care to adult care, and the availability of Maryland Medical Assistance Program enrollees with SCD to seek medical care outside of the state when needed. These proposals were submitted by advocates because they're the barriers of, or they're the recipients of these services. And so they were very specific in what's needed. We know that in October 2007, the Maryland Statewide Steering Committee on Services for Adults with Sickle Cell Disease was formed, and the commission was charged with educating those with sickle cell disease, healthcare providers, and the public about state care and treatment. However, from May 2009 to July 2019, the committee did not meet. It was reactivated by this legislation in 2019, and the committee activities got off to a slow start, but could further be supported by these bills, by this bill that is being proposed. And again, it is worked in conjunction with the Maryland Commission. Maryland would not be the first state to pass legislation such as this one. Tennessee was the first state to pass similar legislation in 2021, and it passed unanimously. And in 2022, the National Black Caucus of State Legislators put out a call to action urging state and federal policy makers to focus on improving care for patients diagnosed with sickle cell disease. This bill is much needed. It's a first step to helping Marylanders with sickle cell disease. I look forward to working with and appreciate the written responses from the Maryland Healthcare Commission and appreciate the support of so many SCD advocates. For these reasons, I urge a favorable report. Thank you.
Thank you, Delegate. And on your panel, I have one witness, Ms. Tanika Hoffman. Ms. Hoffman, are you here?
Yes, I'm here.
Good afternoon.
Hello. Good afternoon. Thank you Madam Chair and the committee. My name is Tanika Hoffman. I am a sickle cell disease warrior and advocate. I lived in Maryland
Ms.
with
Hoffman,
sickle cell
Ms.
disease for the
Hoffman,
majority of
Ms.
my life.
Hoffman, Ms.
The lack
Hoffman.
of resources available to me since childhood has always put me at a
Ms.
yes.
Hoffman, we can't hear you very well.
can
It's
hear
kind
you.
of choppy. Will you be so kind and turn your video off? And maybe that will help.
Yes. Can you hear me?
Very, very poorly. Why don't you try now?
Yes. Yes.
This is better. Thank you. Why don't you get started? Go ahead. Start again.
Can you hear me okay?
No, it's very poor connection. Is it possible
It's
to
better.
take?
Right. Sorry about that.
Okay, that's better.
Okay. Again, my name is Tanika Hoffman, and now, how about now? Can you hear me better?
Yeah, that is a lot better. Did you remove?
Can you hear me
the
better?
cookies? Yes. Yes,
I
we
did.
can.
Okay, sorry about that. So as mentioned before, my name is Tanika Hoffman. I'm a sickle cell patient and warrior, advocate as well. I've lived in Maryland for the majority of my life, and the lack of resources available to me and my family since childhood has always placed me at a disadvantage. From having to travel to Washington, D.C. for care as a child, to living in Prince George's County and attending schools with nurses who are not knowledgeable or trained to manage me when I was in acute care, which is a sickle cell pain crisis. Once I transfer out of peds at the most crucial time for a young sickle cell warrior to adult care, I had no options available to me, resulting in me receiving uneven care and eventually seeking care in Alexandria, Virginia. The favorable approval of Bill 1192 will help give the state a holistic picture of the SCD population in the state of Maryland, which can result in the education of medical providers, patient population, young and old, and the support of sickle cell organizations who are on the ground providing solutions to address health disparities found within our sickle cell population, but often we go forgotten compared to other diseases. I would ask that you all would favorably vote for this bill in helping us warriors acquire the care and access to care that we deserve. Thank you so much, and so sorry for the technical difficulty.
Oh, it happens. We're used to it. Do not worry. I'm so glad you were able to give your testimony, and thank you for sharing your experience with us. Now we're going to open it up to the committee for questions. Are there any questions on House Bill 1192 from the members? Seeing none, thank you so much for your testimony today. And this concludes the bill hearing on House Bill 1192. And Delegate Patterson, thank you for being with us today. Next, we have our pleasure. Next, we have Delegate McComas and Henson, House Bill 1170, Public Health, Sickle Cell Disease Testing at a Community-Based Health Fair. Delegate McComas.
Thank you, Madam Chair and Committee. Delegate Patterson has kind of taken a good bit of my testimony, but I'm going to just repeat a little bit because redundancy is a good thing. Maryland Statewide Steering Committee on Services to Adults with Sickle Cell Disease was established with a statutory authority on October 2007, and it's in the Health General Maryland Code 18-507. And then in December 2008, the committee issued its report advising the public and its officials the situation in Maryland and the need for expanding comprehensive services for adults with sickle cell disease. After the report was issued, the committee went dormant until reacted by Governor Hogan in 2019. Dr. Landskron, co-chairman of the steering committee, opines that the lack of funding to support sickle cell outreach programs as proposed in HB 1170, but doesn't lessen the need for such an outreach. So that's why this bill is to kind of help with sickle cell disease fairs when there's health fairs, so that they can hand out information and hopefully at some point possibly also provide testing. That although the testing of sickle cell disease is done at birth in Maryland since the mid-80s, many mothers do not remember the results of such tests because as the child progresses or they move things get misplaced, and usually the birth is the big thing, and you don't remember all the tests and everything. So this is somewhat underscored by the lack of counseling that really should be provided at the time that such test results are disclosed. And then counseling is an important component of the treatment and should be done periodically. Health fairs are an excellent way to provide information as to the resources for treatment and counseling, and as to the psychosocial issues and genetic considerations. Health fairs are not the fix-all solution to medical needs for the SCD warriors, but this is a step in the right direction in an effort to determine and treat those already afflicted, while distributing information that is shrouded by a lack of service providers that are trained in the diagnosis and treatment of chronic diseases, illnesses as a result of this disease. Testing and subsequent counseling will aid those in the future to make decisions in family planning treatments to be sought to address this catastrophic and painful disease. Health fairs could be conducted in those areas that have a concentration of sickle cell cases in Maryland at the outset, and expanded as the result of concentration of patients are determined. So I would hope that we could get a favorable report for 1170. Anecdotally, I was told by the folks up in Harford County that there was no study to determine that there was a population in Prince George's County that might have needed some specialized facilities for sickle cell, and when they built the new hospital. And I thought that was kind of an interesting thought, because we really should start doing that in all the jurisdictions that have a large component of the folks that might be subject to this disease, because it does affect the Mediterranean countries of Turkey, Greece, and Italy and Spain, as well as sub-Saharan Africa countries, and it does target the Black and Hispanic population. So it's really a devastating disease. And in my next bill, well, actually, I might be able to say what it does as far as causing health problems, because it affects a lot of different systems, and it's really frightening when you think about it. The CDC has a wonderful amount of information that, but it's hard to say who has access to the internet and would be going to the library and looking into what is available online from the CDC. But anyway, that's the testimony in support of 1170.
Thank you for your testimony, Delegate. We appreciate it. Next, we have on your panel, Darlene McLaughlin.
I think Darlene is my aide, and she just submitted the testimony. So
that's fine. How about Cassandra Beverly?
Oh, good.
Thank you. Ms. Beverly, will you be so kind and get started?
Thank you so much, Madam Chair. Good afternoon, members of the committee. My name is Cassandra Beverly. I'm a local attorney here in Harford County. I'm also the chair of the Harford County Caucus of African American Leaders. I'm a member of the Sickle Cell Association of Harford and Cecil counties. I'm also, more importantly, the niece of a person who has lived with sickle cell disease for 71 years. I'm testifying in favor of this bill, and I'm very excited to have heard the prior testimony of Delegate Patterson. I would like to see the health department to be able to conduct more testing at the health fairs that they do in the community. Throughout my life, I have witnessed the severe challenges that living with sickle cell disease causes. The pain that they endure during a sickle cell crisis is hard to witness, and I can't imagine what it's like to bear. For those of you who have had relatives who suffer with chronic illness, you know you can hear the pain in their voice as soon as they begin to talk. When I call my aunt's house, I know when she's having a bad day by the pain in her voice. The innumerable trips to the hospital and the many, many blood transfusions. Access to their status for people in the community vis-a-vis whether or not they have a sickle cell trait or disease can save a child and a family from enduring the pain of this disease. Making testing available at community-based fairs is an excellent way to reach people in the community. Bringing resources to the community instead of waiting for people to come to the health department will significantly increase the number of people who will get tested. I was also going to testify about the registry, but I'm going to ask for a favorable report, and I'd like to thank Delegate McComas for bringing forth this bill, as well as the bill regarding the registry. And I thank you for your attention this afternoon.
Thank you for coming to speak with us. I'm going to open it now for questions from the committee. Are there any questions from the committee? I have Delegate Riley.
Thank you, Madam Chair. Yeah, my question will go to, I guess, to Ms. Cassandra Beverly. Hi, welcome. Good to see you.
Hello, good to see you, Delegate Riley.
Yeah, so basically, after listening to all of these particular bills, so are you saying that the sooner that these folks are detected, early childhood, that the better you can manage their pain, or is there a prescription that they can take? Because you said there's no cure, I believe, right? Is that correct?
There really isn't a cure at this time. There are better treatments that are available because my aunt has been fortunate enough to live to 71 years of age. The average life expectancy, I believe, is about 47. So over the years, I've seen a lot develop, but there's no actual cure for it. So the earlier you can test for it, educate people about it, and provide, effective mitigation is really important. At one point, we're from Georgia originally, and we have lived in the Atlanta area. When I contrast her treatment when she could go to Grady Memorial Hospital, where they have an entire sickle cell wing, where she doesn't have to run a gauntlet just to get to the point where she can get treatment. And I see what's here in Maryland is just it's night and day.
So it's a combination. So it's a combination of things, to where it's a lifestyle changing experience. I'm assuming like diet and everything also helps, not just the medication.
It's not really diet, because it's your blood cells are actually sickled, that they're misshapen, and it causes you not to get enough oxygen in your body. And then the sickle, the misshapen cells, they get stuck and clogged at various parts of your blood vessels, and it causes intense pain. And then they also have to go in for periodic blood transfusions from time to time when the blood level actually drops. So you may have to have a hospital stay and get a unit or two of blood. And this is a constant thing throughout their lives, and they never know when these crises are going to hit rather. But there have been some treatments. I remember when they began using the cancer drug hydroxyurea to help with sickle cell patients. I remember when she began to go to a oncology hematologist as an additional healthcare provider to help manage her condition. So things have gotten better, but there's still a gauntlet. Going to the emergency room and having to answer the same questions when this person has had the same chronic disease throughout their life, but still it's a gauntlet to try to get to the care that they need at a time when they're in a crazy amount of pain.
Okay, so I understand. Okay, thank you so much for that education. Perfect. Thank you for the understanding.
Thank you.
Appreciate it.
Thank you. I know there's a question actually from Delegate Lewis, but before we go there, Delegate McComas, I'm looking at the Department of Health letter of information. And it says that, of course, for children that are born, we do screen for sickle cell trait and disease testing. It says, additionally, Maryland Department of Health provided testing services for sickle cell in adults through 2019. However, the testing services stopped because MDH only received a few specimens per year. In fact, only 8 specimens were received for testing in 2018 and 3 were received in 2019. Therefore, the cost to maintain the equipment, instrument, reagents, and supplies was considerable in comparison to the total number of specimens received for adult sickle cell testing. So my question is, what has the Office of Minority Health and Health Disparity been doing? Because they do grant, they have grants, and they should be in the community. And I know that if you work with the churches and you work in the community different fairs, sort of like we did the vaccination, right? Where we work with trusted sources, that number will improve. Even working with the Black Caucus of Maryland, the Latino Caucus of Maryland. Do you know what they're doing? Because they do have the resources, and this falls within their purview.
Madam Chair, I'm on judiciary, so I have no idea, but I agree with you. I mean, I've been to some events having to do with receptions for our recipient of a Medal of Honor at the Black churches. And obviously, you know, they were very well attended. And in fact, a couple of them, and a lot of different people from the community, and obviously a lot of black folks from the community. So you're right. I mean, the churches would be the best place to start, or just a general fair in the areas, you know, like in the southern part of Harford County. We have large populations of Black communities. So just the awareness, and the way how I got aware of it was I went, they had a reception a couple years ago before COVID about sickle cell, and I sat in there, and it was kind of like, you know, I'm from out west, and so it was a real eye opener. And then in speaking with Mr. Williams, who I think he originally is from California, and California has a really robust program. And so he obviously, his wife suffers from it. And actually they couldn't testify today because he had to go down to Hopkins, and you don't miss those appointments. And the whole idea is that if you kind of lead a very deliberate, you get some exercise, you watch your diet, you try to keep the stress level down, it's very helpful. But the thing is, when you go into a crisis, a lot of times the different emergency rooms don't understand it because they've never seen it, and they think it's something else. And I would like to tell you, because it's really what the organ damage is. 75, well, chronic complications can go underreported, and 75% had evidence of chronic organ damage at autopsy, but only 25% had chronic damage previously when they were alive. Complications of sickle cell disease, the brain, ischemic hemorrhagic stroke, silent cerebral infarction, and cognitive impairment. For your eyes, you can have retinopathy, I'm sorry. Go ahead. Heart and lungs, you can have restrictive lung disease because the blood brings the oxygen, and so because you've got these little sickle cell blood cells that, you know, they stick and everything. You have pulmonary hypertension, restrictive cardiomyopathy, and acute chest syndrome. For the liver and gallbladder, you can have jaundice and gallstones. For the spleen, infraction and hypersplenism. Kidneys, hyposturia, hyperfiltration, glomerulosclerosis, albuminuria, end-stage renal failure, and bones, a vascular necrosis, and others being leg ulcers and prisms. So, and I got all this off of the CDC information about sickle cell anemia.
You're right. It's a pretty serious disease, but you know, we have the Office of Minority Health and Health Disparities that is supposed to focus on a lot of the health disparities in the marginalized Black and Brown communities, right? Because we know the data is there. And I know I'm going to go on for the other questions that we have, but I would like you to do, and I mean it as the chairman of the Public Health Committee, is that I'd like you to set up a meeting, please, with the Office of Minority Health and Health Disparities regarding this particular bill. And I want you to ask them what is their plan to address this, because they do have a budget. And if you need help and you need me to be present, please work with my staff, okay?
Well,
I know,
maybe find out who handles it on appropriations, who has that. That would be helpful too, to pull them in. Because we're policy committees.
that would be Delegate Resnick, okay?
Okay, thank you.
And Delegate Henson, who is one of your co-sponsors, is on appropriation as well.
Okay.
And she's your co-sponsor on this bill, so you should bring her in.
Okay.
Delegate Lewis, do you have a question?
No, Madam Chair.
All right. All right. I see no other questions on this bill. Will you be so kind, Delegate McComas, and follow up on that, please?
Yes, ma'am.
All right. This concludes the bill hearing on House Bill 1170. Next, we have House Bill 1176, Public Health Sickle Cell Disease Registry Establishment. Delegate McComas.
This one is just sort of a bill to try to track how many people have the disease, how many people have the markers. But the idea is to maintain confidentiality for the people. So because at this point, Maryland has very few trained hematologists in Maryland that are well versed in the treatment of sickle cell. And we have absolutely zero in Harford and Cecil counties, or the rural counties of Eastern Shore. The Eastern Shore has more than double the population of sickle cell patients than Harford and Cecil combined, despite the overwhelming numbers of those individuals with positive sickle cell traits. Sickle cell disease patients are forced to travel to Baltimore, Delaware, Washington, DC, and Virginia for expert health care. And if they're in a crisis, that's tough. You know, when you're feeling really horrible and you have to take a road trip to get help. A sickle cell registry would provide the demographic information needed to identify where the sickle cell disease healthcare providers are needed and the facilities for those areas that are required. Sickle cell is a root cause of catastrophic illnesses, and I won't repeat my litany that I just did on the other bill. The chronic organ damage with related complications may go unreported. Sickle cell can affect the brain, eyes, heart, lungs, liver, gallbladder, spleen, kidneys, and bones. This is not even an exhaustive list. There are fellow Marylanders that are suffering without access to the knowledge and health care of, that a sickle cell registry could provide to aid where to go and where to get the best care. And so I think, I hope that you got the map that I got from the Department of Planning from Secretary McCord, kind of showing, mine's in black and white, but hopefully yours is in green, showing kind of the density of population that may have sickle cell disease or the traits. And so those should be used in planning when we're locating infusion centers, because you can't just have a kidney infusion center. It's got to be somebody specialized hematologist that can properly adjust what the infusion should have and be for the patients. So it's not just, you run blood through these people. You have to do the proper I guess analysis, or the proper mixture of the blood and probably nutrients that have to be infused in them. So that's pretty much the genesis of it. And to get a registry, but that will maintain people's confidentiality, but can be used for planning purposes for new and improved healthcare facilities. Thank you, Madam Chair.
Thank you. You have Ms. Cassandra Beverly.
Again, Madam Chair, members of the committee, thank you. My name is Cassandra Beverly, and I am testifying and asking for a favorable report with regard to the bill involving the registry. Anything that helps to identify sickle cell disease patients in order to be able to properly allocate the correct number of resources in terms of actual dollars that are needed to provide the education and treatment, and also to identify where resources should be located. The other thing that I'm hopeful will help is that it will keep sickle cell patients from being treated like drug addicts when they come into the emergency room. Their pain level is so intense that they require very strong pain management, morphine, things like that. And many of them have to add on top of their pain the indignity of being treated like a drug addict when they come into our EDs. So I'm hopeful that as some kind of central registry that perhaps medical providers could locate them in when they come in for treatment, will then remove from them the indignity that they have to suffer of being treated as though they were just someone who was there to get drugs as opposed to having their pain managed. So again, I would like to thank Delegate McComas for putting forward this bill and ask for a favorable report from this committee. Thank you very much.
Thank you for your testimony. Are there any questions from the committee members? Okay. Seeing none, there's Delegate McComas, there is a letter from MACI supporting with amendment, and it actually says that they would like Chris, who's the Maryland Designated Health Information Exchange, to be amended into the bill. Do you have any objection to that?
No. The only question I have is, we were trying to locate, the testimony, and we were unsuccessful as far as on the computer. So if we can get a copy of it, or one of your staff can email the extra letters that you received, that would be great.
Yeah, my staff can do that. Thank you so much. Seeing no other questions, this concludes the bill hearing on House Bill 1176. Thank you for being with us today.
Thank you.
And for your advocacy, we appreciate it. Next, we have House Bill 1213, Delegate Mesgar and McComas.
Good afternoon, Madam Chair, Madam Vice Chair, and of course, great members of my former committee. For the record, Delegate Rick Metzger from District 6 in Baltimore County. Thank you again for the opportunity today to be here. It's always good to be amongst my friends. The purpose of this bill is to establish a state commission on fatherhood under the Department of Human Services. This commission would consist of 25 members appointed by the governor with the advice and consent of the Senate from a geographic diversity for a 4-year term whose interests relate to the status of fatherhood in the state. This commission would meet 6 times a year and elect a chair and a vice chair annually. The Secretary of the Human Services, Secretary of Health, or their designees may participate in the commission, and for non-voting members. An executive director shall be the merit employee, but members of the commission may not receive compensation except reimbursement for standard state travel. And this commission has been long overdue about a dialogue and its issue. And what I need to share with you is, as I have been on my porch many times and just listening to consistency and to people, this questions and situations came up many times. So I got a letter the other day from a gentleman, and I think it's in your testimony as well. His name is Eugene Bokai, and he was a father of 4 beautiful children. For most of their early lives, he was the primary caregiver. And the children were happy, well-adjusted, and successful. Then one day, their happy world was shattered. His wife abandoned him, well, his words are me, and our 4 children, and telling me in crude and uncertain terms that she did not care about the kids and had no interest in raising them. That is until she realized that she could use her means for her financial means. After months of abandonment, one day she asked if she could visit the kids and keep them over the weekend. And instead of returning them, as she agreed, she took the children to the house of Ruth and made false allegations, abuse against, and claiming that she had taken the kids and fled out of fear. From that moment on, this gentleman has been trapped in a nightmare. He's been watched over his innocence. Carefree children struggled to cope with trauma, their lives being uprooted without the guidance of their father. This man's children suffered academically, behaviorally, and was not able to see them. And it was very unclean and unkept, and the sores and bruises and other signs of abuse as well as neglect. At this time, this particular wife continued to manipulate the system and establish for her own benefit. She used the fraudulent protective orders to keep this gentleman from his children. I'm moving down here. This is a system that is very, from the very foundation and the traditional jurisprudence and presumption of innocence. Now, there's no greater pain for a father than to watch his children suffer. But whenever this gentleman turned for help, he was turned away. Now, also, I need to share, this is very personal as well, because when it comes down to child, the suffering and the abuse and so forth, and the balance of finances and so forth, it gets out of hand. And ladies and gentlemen, I'm sure several people signed up to testify on this bill. And I really asked you, let's take a real time. And as Madam Speaker would always, Madam Chair would say, this is time. It's really ready for prime time. So I think that, thank you for your time and your consideration. And I want to turn it back over to my gentleman who's going to be speaking. So thank you.
Thank you for being with us. Next, we have Mr. Tom Henry. Mr. Henry, you have 2 minutes. Good afternoon.
Thank you, ma'am. Thank you, Madam Chair, Madam Vice Chair. Thank you for allowing me to testify in favor of House Bill 1213. Since around the President Johnson's Great Society, the welfare state has done more harm than good, especially when it comes to intact families. And in one important aspect, fathers in the home have been hurt more than society cares to admit. The welfare states created a mindset that government will take care of our mothers and children. But in recent years, we've seen sharp increases in crimes, with smash and grabs, carjacking spiking all across the nation, with juveniles largely responsible for them. Since the pandemic, increases in mental health issues, suicides, crimes, and fear of haunted children who haven't been able to return to school for 2 years. But when it comes to child custody, most states say there's a 50-50 presumption in going to a custody case as dictated by law since the 70s. However, the results show that since 2018, 79.9% of custodial parents in the U.S. were mothers, and only 40% of the states aim to give children equal time with each parent. Our children suffer from fatherlessness. That's why we need this Fatherhood Commission that will shed light on the issues and attitudes that affect fathers and fatherhood in education, social services, employment, law enforcement, health and safety, legal rights, family, human relations, and volunteer services. The results of these efforts can be communicated to executive and legislative branches of state government to propose legislation to properly address wrongful government overreach into family matters, and hopefully overcome the wrongful bias and attitudes held by government which denigrates fathers. As a divorced father, I have firsthand experience of the damage done to a relationship with a father and his children. Without a detailed history, at one point the children told me they don't have to visit with dad if they don't want to. Unfortunately, they were permitted to embrace the parental alienation encouraged by their mother, and there was no remedy offered to assist me by my family law court judges to address it. The relationship with my children has been diminished as a result. I know these cases are shared with you each year. Now you're aware. Thank you for your time. I'm more than willing to answer any questions that you have.
Thank you for sharing your experience with our committee. We appreciate it, sir.
Yes,
Next,
ma'am.
we have our pleasure. Next, we have Mr. Vince McCobb.
Thank you so much. Thank you so much, committee. I appreciate it. This commission is overdue, and I do thank Delegate Metzger for bringing this bill again to your committee and hearing testimony today in favor of HB 1213, Commission for Fatherhood. I wrote it, and we amended it this year because of some comments last year regarding buildings and running for election. That's not the core of this. The core of this is where fathers are integrated into society and integrated into family. When that breakdown happens, the issues that you just heard by Mr. Henry are going to be coming about. And we know this to be the case. You can actually plot where we have fatherlessness in Maryland and a disproportionate amount of crime. This is no mystery. This is data that's been going on for years and years. When I get done my testimony, I'm going to send you an email, something I sent to the judiciary, because they're very concerned about this. Frankly, they should be hearing this bill. We'll see about that in the future. But we're looking at policy, systems, and family law attacks on Maryland fathers. I've expressed this to this commission, to this committee and others, notably JPR and Judiciary, for years, for a decade. So we know that this is not happenstance when fathers keep coming in and expressing this. What I'm advocating for this commission is to have an agnostic view of the data. And wherever the data leads us, that's where we go. These are the policies that can help out for the fathers, for society, for the financials, for society, but also for the society and love between a father and his children. This state egregiously disregards that connection, that tie, and that God-given bond that is allowed and it's not to be interrupted by the state without parens patriae. We don't have a good reason, and we do in maybe 0.5% of fathers in total, the state or the nation. You're never going to hear me advocate for bad parenting, ever. But the point being, what about the other 99.95%? I urge and favorable on this. Look at this from the perspectives of your constituents. 40% of Marylanders are fathers. Thank you so much.
Thank you for your testimony. We have Mr. Eric Smith. Mr. Smith, you have 2 minutes.
Yes, hi. I come to you
Good
today.
afternoon.
I'm coming to you today from our nonprofit program called Winning Strategies, Fatherhood, the Courts of Custody. We assist fathers here in the Baltimore City, Baltimore County area with filling out the paperwork, with filing pro se. Okay. However, when they get to court, they are sometimes met with the judges and judicial appointees that do not follow procedural law. That is a violation, we say, to the best interest of the child, because a lot of times following the best interest of the child standard means giving 50-50, full 50-50 custody to both parents helps. Now, also, when we look at the judges and judicial appointees turn on things, they really don't like to follow procedural law. Okay, they want to put in their brand of justice. Okay, we just submitted testimony for House Bill 338, which was for Delegate Lopez, and against House Bill 104 by Atterbury. Okay, because that was an attack against fathers. Those bills are really attacks, and having this commission to study what's going on in the state of Maryland towards fathers would help. Lastly, I would like to point out that with Winning Strategies, a program that was talked about with my wife and a very good friend of mine, we're able to help the fathers here in Baltimore City. Okay, we're helping fathers in Baltimore County, and fathers in Howard County are reaching out to us as well. Okay, with this bill, this can be looked at throughout the state of Maryland. This needs to be looked at. Fathers are hurting. We are here. We want to help. Thank you.
Thank you for your testimony today, Mr. Smith. We appreciate it. Now we're going to open it for questions. Any questions from the committee? Seeing none, that this concludes the real hearing on House Bill 1213. Members, we're going to take a 10-minute break, 10 minutes only, please, so that you can stretch or go get some water, but we're going to come back because we have to be on the floor at 6, and we're going to get through this work quickly, okay? 10 minutes. It is now 4:08. If you can be back by 4:18, that would be wonderful. Thank you.
Thank you, Madam Chair.
Thank you. Okay, 4:18, we're gonna get started. Good afternoon. Welcome back to the Health and Government Operations Committee, Chairman Pendergrass. My name is Jocelyn Pena-Melnick, and we are back to, we're gonna call House Bill 1214, Delegate McComas, the Maryland Child Protection Act of 2022. Delegate McComas, you have 5 minutes. Will you please get started?
Okay, thank you, Madam Chair. Thank you, committee. This is in support of HB 1214. It proposes to protect important and compelling state interests. One, protecting children from sexually predatory adults, thus clarifying the definition of abuse to include sexual predators and traffickers and statutory rapists. Two, ensuring that adults who are involved in illegal sexual relationships or contact with children are reported, investigated, and when warranted, prosecuted. Under the current law, abortion providers evade mandatory reporting requirements because the definition of sexual abuse is too narrow. Abortion providers incorrectly believe that mandatory reporting requirements do not apply to them because providers claim that they are not required to report because of privacy laws or doctor-patient privilege, thus aiding sex traffickers to continue the abuse cycle. Relieving abortion providers as mandatory reporters of suspected child crimes against children from any responsibility to personally investigate an allegation or suspicion. Abortion providers must simply report allegations, suspicions, and pertinent facts. Trained law enforcement or social service personnel will then be responsible for any investigation for the ultimate disposition of the allegations or cases. Reducing physical and emotional, developmental, and psychological impact of sexual crimes on child victims, thus reducing the societal and economic burdens on the populace that result from sexual crimes against children. Also, ACEs, and I'm sure the committee is very familiar with adverse childhood experiences. 5, providing law enforcement officials with the tools and evidence necessary to investigate and prosecute child predators and child sex traffickers. And 6, protecting and respecting the right of parents and guardians to be involved in the medical decisions and treatment of their children and preventing anyone from knowingly or willfully subverting or circumventing these rights. HB 1214 is needed because children are increasingly being preyed upon, victimized, and coerced into illegal sexual relationships by adults for sex trafficking purposes. State law should require caretakers, healthcare facilities, healthcare providers, teachers, and other specified individuals to report suspected incidents of sexual crimes against children. However, many of these suspected criminal acts go unreported, and the perpetrators are not investigated or prosecuted. Maryland may better prevent future criminal crimes against children by investigating, prosecuting, incarcerating, and treating those who prey upon and victimize children. To prevent the future and continuing sexual crimes against children, all suspected crimes of this nature must be reported to state investigators and agencies that are specifically trained and equipped to professionally, thoroughly, and compassionately investigate cases of suspected crimes against children while relieving mandatory reporters of any investigatory responsibility. The physical, emotional, developmental, and psychological impact of sexual crimes on children victims can be severe and long-lasting. The societal costs of these crimes are also significant and affect the entire population. This provides law enforcement the support needed to prosecute the sex crimes through collection, maintenance, and preservation of evidence, including forensic tissue samples. Thus, 1214 furthers Maryland's interest in protecting children from sexual crimes and provides the state with the necessary tool for successful investigations and prosecutions. Parents and guardians have both the right and responsibility to be involved in the medical treatment decisions involving their children. No one has the right to knowingly or willfully impede or circumvent this right. There are documented cases of individuals other than a parent and guardian who were aiding, abetting, and assisting minor girls to procure abortions without their parents, guardians' knowledge, consent, or involvement. This includes transporting children across state lines to avoid Maryland's parental notification requirements for abortion. Such actions violate both the sanctity of the familial relationship and Maryland's parental notification law regarding abortion. Please provide a favorable report for HB 1214. Thank you, Madam Chair.
Thank you so much for your testimony. Next, we have Ms. Pamela Palumbo. And you have 2 minutes, ma'am. Good afternoon.
Thank you. My name is Pamela Palumbo, and I serve as the president of the Maryland Coalition of Medical Pregnancy Clinics with 30 clinics across the state of Maryland, serving 20,000 women a year. I urge you to vote in favor of HB 1214, Maryland's child protection law, which offers additional protection for teen girls 14 and under who may be victims of sexual abuse or abortion coercion. Well, we would all like to think this isn't happening. That's absolutely not the case. I speak from direct experience of caring for young women as young as 14 and under who are pregnant, and nearly all have adults encouraging those abortions. With just a quick email to our Maryland Coalition members, I received information from just 5 who then report over 35 cases of pregnant teens 14 and under they have seen in this past year. Our coalition members take protection of women serious and follow guidelines for mandatory reporting. However, that isn't the case with everybody, particularly those profiting from abortion. Congresswoman Vicky Hartzler, Missouri, and 55 other members of Congress called on the U.S. Department of Health and Human Services to investigate Planned Parenthood after a report came out of longstanding pattern of that organization's failure to report the sexual abuse of minor girls who were as young as 12 and 13 and were brought into Planned Parenthood for abortions. It is unthinkable that Planned Parenthood would perform an abortion on a young girl with no questions asked. However, this does happen. Without this bill, abortionists and perpetrators can hide, abuse, and sexually exploit continue. Case courses need evidence, and only by the collection of fetal tissue samples will there be proof positive of who may have impregnated that young teen. This law will simply help us close loopholes, better ensure mandatory reporting, and increase basic protection for our young pregnant teenage girls in Maryland. I urge you to vote in favor of HB 1214, Maryland's Child Protection Law of 2022. Thank you very much.
Thank you for being with us today. We appreciate it. Ms. Hannah Wolf. Ms. Wolf, you have 2 minutes. Good afternoon.
Hi, good afternoon. My name is Hannah Wolf. I'm a representative of Students for Life Action. Students for Life Action and Students for Life of America are grassroots organizations that are present in all 50 states on more than 1,300 middle school, high school, college and university, and medical and law school campuses. And we exist on 29 campuses here in Maryland. And I'm here to stand in support of the Maryland Child Protection Act of 2022. Given how easily accessible abortion is in Maryland already to young girls experiencing such traumatic situations, this bill would serve as an added layer of protection for those who are being abused and or coerced into their decision to undergo an abortion by an abuser. By ensuring that abortion providers know they're required to report suspected child abuse and subjecting those who fail to act to penalty, as the bill states, young girls who become pregnant would be further protected from coercion into abortion, which often allows the sexual abuse and exploitation to continue. This issue is of personal importance to me. I had a friend at only 12 years old who became pregnant while we were in middle school, and we weren't just shocked to find the news of her pregnancy, but also the fact that this had occurred through sexual abuse that she had endured in her own household. Had those who discovered the abuse not reported it, she easily could have been pressured into an abortion procedure by her abuser, which then would have allowed him to continue in his reign of terror in her life and subjected her to further trauma. Instead, she was protected from this by those who stood up for her and was given the courage to choose life for her child. And this was a decision she's never regretted. She continues today as an amazing mother to a 12-year-old daughter. This bill gives us the opportunity to protect children in our state from such abuse, as was experienced by my friend. And it paves the way for a culture in Maryland that protects our most vulnerable, including young girls and potentially their preborn children. I ask you to see the importance of this bill and vote in favor of it. Thank you.
Thank you for your testimony. Next, we have Ms. Deborah Brocato.
Hello, this is Deborah Brocato, and I'm speaking in favor of Bill 1214. As a mother of 4 daughters, I'm very happy to see that Section F provides that there must be parental notification for a minor seeking an abortion. If a minor is seeking an abortion, then it means she has had intercourse. Because she is a minor, it will be important to know the circumstances of her sexual relationship to determine whether or not there is sexual abuse or sexual coercion. The parents may or may not know of their daughter's pregnancy or of their daughter's sexual activity. Being the primary caretakers of our children, parents have a right to know what is happening in their children's lives, especially when there may be predatory activity and or a life-threatening procedure involved. As a mother of 4 daughters who, with my husband, has worked hard to raise them and provide the best possible guidance for them, I know that it is the mothers and fathers who have the best interests of their children in mind. We are the ones responsible for the health and well-being of our children. A minor daughter facing a pregnancy needs her parents, not unrelated people like the abortion center employees, directing her to make a decision that financially benefits them. If the pregnancy is a result of sexual abuse or sexual coercion, it will be up to the mothers and fathers to guide their daughter through it and provide the appropriate medical and psychological treatment. Part E addresses the necessity of preserving evidence if sexual abuse or sexual coercion has occurred and the parents and daughter choose to end the life of the baby is evidence of the criminal behavior. Anytime a minor is receiving an abortion, the evidence of the pregnancy needs to be preserved. We know that victims of abuse are often too afraid at the time to admit to what has happened. Therefore, the remains of the pregnancy must be preserved for potential investigations. And I like that Part G provides that those who refuse to report abuse, fail to notify parents, or fail to preserve evidence will be obstructed from repeating these harmful acts. So it is for these reasons that I urge all of you to recognize the need to protect our daughters and vote in favor of this bill. Thank you so much for your time.
Thank you for being with us today. I appreciate it. Next, we have Ms. Jennifer Brinker. Ms. Brinker, good afternoon. Are you here? Ms. Jennifer Brinker, Susanna or Richard, is she here?
Yes, and she is unmuted, but we can't hear her.
Ms. Brinker, can you hear me? Well, can you speak? You can speak. We can't hear you. I tell you what, I'm going to go to the next witness to give you a little time to figure it out, okay? It's all right. It will work out. Next, we have Ms. Laura Bugley. Good afternoon, ma'am. You have 2 minutes.
Thank you, Madam Vice Chair and members of the
My pleasure.
I'm Laura Bogley, Director of Legislation for Maryland Right to Life. We want to thank Delegate McComas for bringing this bill, which is critically important to protect the health and welfare of minors who too often become victims of sexual predators. This bill clarifies and strengthens the existing Maryland mandatory reporter law that requires health practitioners and others to report incidents of suspected child abuse to appropriate authorities. This bill in no way infringes on a woman's right to abortion, nor does it prohibit abortion in the case of rape or incest. This bill is particularly important in Maryland, where girls are being trafficked across state lines to evade parental consent laws and other safeguards enacted by other states. There's substantial and developing evidence that many family planning and abortion clinics are not reporting all incidents of suspected abuse and are in some cases advising minors and their abusers how to actually circumvent that law. In your packets, I've provided you a copy of a 2020 news article detailing how Jeffrey Epstein used abortion coercion as a tool to continue to rape girls and exploit them for money and power. If the abortion provider had reported this incident, this girl and countless others may have been rescued from the evil clutches of Jeffrey Epstein. Unfortunately, this is not an isolated incident. This bill solves that problem by clarifying that an abortion provider is, in fact, a mandatory reporter under Maryland law, and that the doctor-patient privilege is not an exception to that reporting requirement. Finally, this bill helps law enforcement authorities to enforce existing law and protect children from sexual predators by creating an affirmative duty to preserve evidence of a suspected sex crime against a minor. We urge you to protect children, not predators, and to pass this bill. Thank you.
Thank you for your testimony today. The committee appreciates it. Ms. Brinker, were you able to solve your problem? No, it's not working. Why don't you sign out and come back again, okay? Quickly, thank you. And while she does that, are there any questions for this panel? Second. Delegate Riley.
Thank you, Madam Chair. Yeah, I was reading some of the opposition to this bill, and a lot of them repeat the fact that they think that the reporting that's in this particular bill would jeopardize the other reporting for sexual abuse. Whoever is best to answer that could help me out with that information. I'd be grateful.
So in this committee, we allow one person to answer the question. Delegate McComas, who's the best person on your panel to answer that question?
I would say Ms. Bogley.
Ms. Bogley, will you be so kind and address the question?
All right, thank you, Delegate McComas, and thank you, Delegate Riley, for the question. I'm not sure I understand the nature of the opposition. You're saying that they believe that the
reporting in this bill would jeopardize the current reporting that is done on sexual abuse.
We absolutely disagree. We believe that it enhances the current reporting requirement and gives the state additional tools in order to make sure that that is being applied equitably across the board, evenly to all providers. So we think that this is an enhancement. It does not in any way conflict with the current law or definitions.
Okay, great. And I believe the article that you probably gave us as well kind of backs that up, showing how that happened, numerous cases, times over and over, and the reporting that, I don't know if the reporting there is the same as it is here, but I'm sure they do have sexual abuse reporting that was totally ignored. So
Right.
Thank you very much.
It's important to note, Delegate Riley, that the current law already says that the doctor-patient privilege is not an exception or does not excuse an otherwise reporter from reporting. So I think oftentimes abortion providers believe that HIPAA or privacy prevents them from reporting to the appropriate authorities. And the bill has already addressed that and said that is not the case. That is not an exception to this law.
Okay, thank you, Ms. Burgundy, for pointing that out. Thank you.
Thank you.
Thank you. Seeing no other questions, I'm going to go back to Ms. Brinker.
Can you hear me now?
Yes, we can.
Oh my goodness. Okay, thank you. So I'm Jennifer Brinker. Yep, I'm a licensed clinical social worker in the state of Maryland. It is both a privilege and a tremendous responsibility of mandatory reporters to assist in the safety and well-being of young people by making reports of suspected abuse to the appropriate authorities. I know that those of us who are mandatory reporters have an ability and a duty to protect the innocent and vulnerable in a way that other citizens are called to do by their civic duty, but which we are impelled to do by virtue of our professions. Young victims of sexual crimes, including trafficking, often cannot speak for themselves adequately, as the trauma, the confusion, and the betrayal caused by being used and abused deeply affects their social and emotional development. The Rape, Abuse, and Incest National Network outlines some of the long-term impacts of child sex abuse, citing victims of sexual abuse are 4 times more likely to develop symptoms of drug abuse and/or experience PTSD as adults, and 3 times more likely to experience a major depressive episode as adults. Timely reports combined with supporting forensic evidence is critical to investigations of sex crimes and could help punish those who perpetrate sexual crimes against our young people and prevent them from harming others. I am asking for a favorable report of HB 1214 because it will help collect forensic DNA evidence through the fetal tissue, aiding in the prosecution of perpetrators of child sex crimes. Requiring the collection of such samples will help ensure that those health practitioners who have the capacity to collect such evidence will have done all they can as mandatory reporters of abuse to protect victims. As a mental health professional, I count on my fellow professionals to help ensure that young victims of maltreatment are not further marginalized and silenced by the very people who have the ability to protect them. This legislation would ensure that we maximize the use of forensic evidence to protect young people in the state of Maryland. Thank you very much, and thank you for your patience.
It was our pleasure to give you the time to testify. Are there any questions for Ms. Brinker? Seeing none, thank you so much for being with us today. And this concludes the bill hearing on House Bill 1214. Next, we have House Bill 775, Delegate McIntosh, Maryland Pediatric Cancer Fund, Establishment and Income Tax Checkoff. We do have our esteemed colleagues from the Ways and Means Committee, Delegates Long, Philmark, and Delegate Barnes. And delegates, you're welcome to ask questions when we come to that portion. Delegate Chairman McIntosh is not with us. She has something very important to take care of, but her amazing Chief of Staff, Dana Phillips, will be providing the testimony today on House Bill 775.
Thank you. Good afternoon, Chair Pendergrass, Vice Chair Penny Melnick, members of the committee. I am grateful for your time and attention today. My name is Dana Phillips, and I am Chairman McIntosh's Chief of Staff. I'm here on her behalf today to present House Bill 775, Maryland Pediatric Cancer Fund Establishment and Income Tax Checkoff. Last week, during the President's State of the Union address, Biden pledged to continue to invest in finding the cure for cancer. Like so many others, my family breathed a sigh of relief because years ago, my parents' life was flipped upside down when my older brother was diagnosed with Wilms tumor, a type of childhood cancer that starts in the kidney at 4 years old. After undergoing 6 months of chemotherapy and losing a kidney, Don's treatment successfully led to remission. That wasn't without the significant effects on his body to this day that he still deals with. At 28, he will never know a body that had not been put through chemotherapy. With only one kidney, he was considered high risk during the COVID pandemic, and because of his naturally weaker immune system and proneness to blood clots and kidney stones. Chairwoman McIntosh is introducing this bill because she too has also been thrown into the unfortunate world of childhood cancer. In August of 2020, Chair McIntosh and her wife Diane got the call that their 2-year-old granddaughter had been diagnosed with childhood leukemia. Today, in 2022, at the age of 4, she is still finishing her treatment. Phoebe's health continues to improve. She has her energy back, has started to regrow her hair, and enjoys being a big sister to her brother. However, she was put on extensive medication, and amid the beginning of her treatment, which left her young body confused with low energy and in pain, all of which was immensely difficult for her family. When a child gets cancer, the entire family must jump in, all hands on deck. Childhood cancer research and treatment is an unmet medical need in the state of Maryland. We have not done enough for the treatment and specifically for the post-care treatment for children affected by cancer. And we have the opportunity at the state level to provide families dealing with childhood cancer with more support. This bill establishes the Maryland Pediatric Cancer Fund to fund pediatric cancer research, prevention, and treatment. The fund will come from voluntary contributions on individual income tax returns and other donations, and will be administered by the Secretary of Health, who will be under the advisement of the Maryland Pediatric Cancer Advisory Committee. Again, we have the wonderful opportunity at the state level to provide more support for families. Thank you guys so much for your time, and I hope that you vote favorably for HB 775. I was going to use the remainder of my time to introduce a member of our panel, Aubrey, who is the Director of Community Engagement for the Childhood Cancer Organization.
Thank you so much, Dana. Hi, I'm Aubrey. I apologize. I have a little bit of a cold, so I'm a little froggy. But thank you, Madam Chair, and the rest of the committee for your time today. As Dana said, I'm Aubrey Reichert-Eline from the American Childhood Cancer Organization, and I'm here today regarding childhood cancer in Maryland, and I'm representing not only ACCO, which is a Maryland-based national childhood cancer organization, but I'm also here on behalf of the childhood cancer community. On April 8th, 2018, my family was not a cancer family. On April 9th, 2018, my family became a cancer family when my then 9-year-old daughter, Grace, was diagnosed with a brain tumor. She immediately traded in her softball glove for many rounds of chemotherapy and 24 rounds of radiation. She's currently showing no evidence of disease, and I'm dedicated to helping others that are in this situation dealing with childhood cancer and pay it forward. Cancer is not something you want in your vocabulary, in your home, and definitely not with your child. The majority of spending at the federal level on cancer research goes to adults. Adults are important, but we ask at ACCO, what about kids? Pediatric cancer is the #1 death by disease in this country and in this state of Maryland. Maryland is number 13 in the country for pediatric incidence rates of lymphoma, according to a CDC report. And 3 Maryland counties are showing higher mortality rates for pediatric cancer than the national average. That's according to cancer.gov. States can make a difference and have the opportunity to make up the disparity in pediatric cancer research funding. ACCO is taking the lead on securing state funding, and we have success in Pennsylvania, Kentucky, and New Jersey. The money raised at the state level stays within the state, and the appropriations that ACCO has acquired in the past year and secured in these 3 other states equates to $30 million, which is the same as the federal level for the STAR Act, for the Federal STAR Act. I know that Maryland can lead this country in implementing state pediatric cancer research funding. Together, we can make a difference for these kids in Maryland. With cancer and this more funding, we'll be able to do more research so that there's less toxic treatments and more survivors. We can also protect those survivors from a lifetime of side effects, like Dana had noted before. My life is marked forever by before pediatric cancer and after pediatric cancer. I'm thankful that my daughter gets an after, and I'm determined to make a difference and an impact for those that are fighting this disease today. I'm here for Grace, for Mason, for Sully, for Naomi, and for Ethan. This is the approximate number of children that will be diagnosed with pediatric cancer in the state of Maryland just this week. Let's make a difference for them with Bill HB 775. Thank you so much for your time and consideration today. I'm going to give my extra time over to some of my other counterparts that are on this call today, and I'm going to actually turn it over right now to Amy and Sully that are on the call, and then Ruth, and they can have some of my extra time. So thank you all so much for your consideration today.
All right. So why don't we go on to Amy, followed by Ms. Shields, and followed by Ms. Hoffman. Amy.
Madam Chair, if you don't mind, Sully and I would like to combine our time. We should both be listed.
Oh, you are both listed,
Okay,
so you
perfect.
have 4 minutes.
Thank
Go
you.
ahead.
I appreciate that.
My pleasure.
My name is Amy Shields, and this is my son, Sully.
Hello.
We're here to testify in support of House Bill 775, the establishment of a pediatric cancer fund in the state of Maryland. As you heard Aubrey say, according to cancer.gov, there's an estimated 5 children per week that are diagnosed with pediatric cancer in Maryland. On March 28th, 2014, just shy of his 5th birthday, Sully became one of them. Sully was diagnosed with stage 4 neuroblastoma. At the time of his diagnosis, he had an 11-centimeter tumor between his stomach and his spine. The bones in his skull, his shoulder, his hips, his femurs, and his knees all contained cancer cells, and 95% of his bone marrow was made up of cancer. After consulting with several different hospitals, we learned there is no standard treatment for neuroblastoma. Every child is put into a clinical trial. Within a week of diagnosis, Sully was enrolled in a trial and started chemo. Over the next 5.5 years, Sully endured 5 surgeries, 29 rounds of chemotherapy, each lasting 1 to 3 weeks. 5 rounds of immunotherapy, 8 rounds of immunotherapy combined with chemotherapy, 3 rounds of MIBG therapy, which is targeted internal radiation, where they actually will pump radiation into his body. We were not allowed to touch him or go near him for multiple days. He was a little bit too radioactive for that. He did 1 month of daily photon radiation, 1 month of daily proton radiation, which was done to his skull. So as a 7-year-old, he was actually screwed down to a table so that he wouldn't move and they could get him in the right position. He had a stem cell transplant that kept him in the hospital for the entire month of December in 2015. He spent over 150 nights in the hospital, had 2 life-threatening reactions to medications, more blood and platelet transfusions than I can count, and he relapsed twice. In total, Sully spent 1,667 days in treatment. We are so grateful that Sully is alive. And at the same time, we are living with the fallout of his toxic treatment every single day. Sully's team now includes oncology. He has follow-ups every few months, and when strange symptoms pop up, which they often do, my first call is not a pediatrician, it's an oncologist. He sees an endocrinologist because the radiation shot his thyroid, and now he has to be on medication for the rest of his life. He didn't grow for 1.5 years during treatment, so we may need to supplement with human growth hormone. And they follow his hormones in general because Sully, like most cancer kids, will not be able to have biological children. He has an orthopedic for his leg and spine. Radiation stunted the growth in one of his legs, so he'll need to have extensive surgery to either shorten the long leg or lengthen the short leg to make his legs even. He has an ENT because radiation scarred his lung sac, so he's unable to properly take a deep breath. Gastroenterology for fatty liver disease and non-alcoholic liver cirrhosis, audiology for high-frequency hearing loss, cardiology for the damage to his heart from the chemo, and learning specialists for his ADHD. We learned so much through all of this, but we also learned what Aubrey mentioned, that only 4% of federal cancer research dollars are spent on all childhood cancers combined, and that most states, Maryland included, don't do anything about childhood cancer. That needs to change, and we need your help to change it.
Yeah, I just am here to say that I am one of the lucky. I made it out with so many problems, so many things that I had to do, but I am pretty lucky compared to almost everybody that I've seen. It's very lucky that I survived, and there would be a lot more children like me if there was just more research. And even though that I have so many scars, there's so many people with more stuff than me, and that just needs to end.
Sally, I have to say that the committee appreciates your testimony. It's really meaningful and impactful, and I'm sorry that you are going through what you're, experiencing, but you have an amazing mom and support system there, and that's wonderful. And the committee appreciates your testimony today, okay?
Thank you.
And I wish you many blessings for good health, okay? So next we have, my pleasure. Next we have Ms. Hoffman, and Ms. Hoffman, you have 4 minutes.
Thank you, Madam Chair and members of the committee. My name is Ruth Hoffman, for the record. I am the CEO of the American Childhood Cancer Organization, which, as Aubrey mentioned, is located in Maryland. But most importantly, I'm the mother of 8 children, including my daughter, who at age 7 in 1987 was one of the first kids to survive a bone marrow transplant as treatment for acute myelogenous leukemia. Childhood cancer research and treatment represent an unmet medical need. It is the #1 cause of death by disease of kids in Maryland, in the United States, and around the world. Only 5 new drugs have been approved by the FDA to specifically treat childhood cancer in the last 3 decades. That compares to more than 200 drugs approved to treat adult cancers. This means that children diagnosed today with acute monocytic leukemia, or the cancer that my daughter had, will receive the exact same treatment that she had 35 years ago. It's not good enough. Treatment for childhood cancer, as Sully mentioned and as Amy mentioned, is toxic. Most of the children are burned through radiation, poisoned through chemotherapy, or cut with surgery in hope of finding a cure. My daughter's oncologist described her total body radiation as deliberately performing a nuclear bomb in a kid. Children are receiving these toxic therapies at a time in their lives when they have growing bodies and developing brains. The impact is forever. Children suffer secondary cancers, endocrine dysfunction, heart and lung damage, cognitive impairment, infertility, and more. And my daughter's cancer also impacted the next generation. The total body radiation as a 7-year-old that she received resulted in vascular uterine insufficiency and cervical incompetency. When she got pregnant as a young adult, she had to have her baby induced at 24 weeks. Hope was born weighing 1 pound 6 ounces, and as a result of that has grand mal epilepsy. We have to do better. We have to ask the question in Maryland, what about kids? And I encourage you to support HB 775.
Thank you. Are there any questions for this panel? 1 second, please. Okay. All right, seeing no questions, this actually concludes the bill hearing on House Bill 775. We want to thank you for being with us today, and thank you for your advocacy and leadership, okay? Take care, Sully. Next, we have actually House Bill 1329, and then we have the last bill of the day, 1381. 1321 is actually 1329 is Delegate Jalisi, Suicide Treatment Improvement Act. Good afternoon, Delegate Jalisi. You have 5 minutes. Will you be so kind and get started, please? Is Delegate Jalisi here?
Just came. 1 second.
Okay. Delegate Jalisi, are you there? Okay.
Yeah. Hi, Vice Chair Penya Melnick, esteemed members of the House and Government Operations Committee. I come before you to testify in support of my bill, HB 1329, which is the Suicide Treatment and Improvement Act. This bill proposes that the Maryland Department of Health provide training for employees who encountered someone who's suicidal or has attempted suicide previously. This includes suicide hotline counselors, mental health facility employees, and police officers who may respond to calls involving suicides. In the last 2 years, we've seen very challenging times for everyone, but especially for those struggling with mental illnesses. In a June 2020 national survey discovered that 40% of the adults with struggling mental health and substance abuse, and vast majority of them are young adults. I believe that it is responsible and prudent for us to invest in the well-being of residents living with mental illnesses. And my bill helps to prevent suicides, which may be caused in such individuals. For these reasons, I urge you to support HB 1329, and I request a favorable report. Thank you very much.
Thank you for your testimony, Delegate. Now we go to the portion of questions. Are there any questions from the committee? Okay, seeing none, this concludes the bill hearing on House Bill 1329. And we're now at the last hearing of the day, House Bill 1381, Delegate Young, Environment Firefighting Training, Oriented Strand Board Prohibition. Good afternoon, Delegate Young. You have 5 minutes.
Good afternoon. Thank you, Madam Chair, members of the committee. Happy to be back in front of you to present HB 1381, Environment Firefighting Training and Oriented Strand Board Prohibitions. You have my testimony, so I'll be brief. Essentially, what the bill does, it prohibits the use of oriented strand board for use during firefighting training, for burning, or for any sort of type of training related to first responders and firefighter training. So in the past, this committee has heard restrictions on use of certain types of chemicals, as well as certain types of things in firefighter training. This is an extension of those prohibitions where there are concerns related to the chemicals used, providing or producing long-term health effects for our first responders. So we have a long tradition of protecting our firefighters, recognizing that the current standards and current materials that we use in order to train them to do jobs that a lot of us would otherwise choose not to do. And this stays in that tradition of making sure that we're protecting our firefighters, we're listening to them and understanding that there are long-term effects associated with the job that they do, and that we're taking that into consideration into their training and making sure that we're taking care of them from the beginning all the way through the end of their career. With that, I do have a panel that, Madam Chair, you can introduce at your leisure, but with that, I urge a favorable report and look forward to the conversation. Thank you.
Thank you so much. We appreciate your testimony. First, we have Mr. Jeffrey Buttle. Good afternoon, sir.
Good afternoon, Madam Chair. How are you?
I'm doing well. Thank you for asking.
Good. Jeff Buttle on behalf of the Professional Firefighters of Maryland, which is the state level affiliate of the International Association of Firefighters, comprised of locals at the federal, state, and local level, which combined represent over 12,000 active and retired fire, rescue, and emergency services personnel. This bill before this committee is another bill focused on firefighter health and safety. Very unfortunately, cancer is now the leading cause of firefighter deaths. And what is causing cancer in firefighters is our long-term exposures to toxins that we experience throughout our careers. This particular piece of legislation would get Maryland on the forefront of oriented strand board and a prohibition on burning it during live fire training, which is what the bill focuses on. Virginia last year recently passed similar legislation to this. It is so Maryland has an opportunity to be really on the second state that has been proactive on this. We look forward to working with the bill sponsor on some of the specifics that may come up before the committee or the subcommittee. But this is a really, really important piece of legislation that will serve to protect the long-term health of our firefighters and hopefully prevent them from being exposed to the toxic byproducts that over time cause them cancer. So it's always a pleasure to be before the committee, Madam Chair, and I hope we can work our way towards a favorable report on this piece of legislation. Thank you.
Well, thank you for your advocacy and for your service. We appreciate it. Our pleasure. Next, we have Mr. Grant Walker.
Good afternoon. Thank you for having us here today for the committee. My name is Grant Walker. I am the first district representative for the Professional Firefighters of Maryland. and a vice president for the Prince George's County Professional Firefighters and Paramedics Association. I'm a lieutenant with the Prince George's County Fire and EMS Department. Thank you for having us back in your committee to discuss another risk reduction measure that will help us reduce firefighter exposure to harmful chemicals, which are killing my brothers and sisters. Cancer is the leading cause of death for Maryland firefighters due to prolonged exposure to carcinogenic substances. Statistically, firefighters are 65% more likely to contract cancer than the general population and have a 14% increased risk of dying from cancer. The best way to protect our firefighters from getting occupational cancers is to reduce the exposure to these carcinogenic substances. We must eliminate the unnecessary exposure to these potentially cancer-causing materials to firefighters. Current research indicates that exposure to carcinogens and other hazardous products and benzene, certain are burned. Some of the products are regularly burned and release a significant level of these products compared to others. Among these is Orient, which contains cancer-causing adhesives. We find this legislation would prohibit the burning of OSB during live fire training schools and live fire training structures. We're looking forward to working with bill sponsors of the committee to address any concerns that they may have with this bill, and we urge a favorable report for HB 1381. Thank you for your time.
And Madam Chair, if I may, not to interject, just wanted to make sure that folks from the committee knew that we've been working with advocates about specific language and potential amendments, and we'll be working those with those advocates as well. So.
Well, that's great because we do have two favorable with amendments. So we're going to open it up now for questions to this favorable panel, and then we'll come back to the two favorable with amendment. And that's good to know that you're working on it because we will ask you to do that. So let's open it up for questions for this panel. Any questions from the committee? Okay, I don't see any questions. So let's go to the favorable with amendment. First, we have Stephen Gioroni, and I'm so sorry if I did not pronounce your name.
Thank you, Madam Chairman. That's been happening most of my life. Thank you to the members of the committee for allowing me to provide feedback on HB 1381. My name is Stephen Gioroni, and I represent the American Chemistry
I did
Council.
pretty well, though.
Yes, pretty well. Yes.
It's okay. I can relate with Pena Melnick. Go ahead.
ACC supports efforts to protect firefighters from harmful chemicals and harmful combustion byproducts from chemicals or the products of chemistry. First responders are critical to the protection of lives, homes, and buildings. Firefighters are often working and training in extreme conditions, and therefore special consideration should be given to the potential exposures to protect their health. A reasonable safety measures to control and ensure the products used in live fire training exercises do not unnecessarily expose firefighters to harmful combustion byproducts. ACC is opposed to any reference to PMDI as a chemical of concern in HB 1381. References to PMDI as a source of increased emissions from OSB products are not supported by current science, and PMDI is not a carcinogen. There are two studies measuring emissions from OSB during live fire training exercises, both under the guidance of Dr. Kenny Fent. These two papers are outlined in the written comments. The second paper, written in 2020, did identify increased emissions from two OSB products. The paper focused on aggregate emissions and did not attempt to identify any chemical component as a potential source. Recently, a similar ban was presented to the National Fire Protection Association and in Virginia. Opponents in the NFPA action stated that previously referenced study did not provide a complete justification on the ban. In Virginia, the bill was amended to remove any reference to PMDI. Accordingly, we are supporting a small technical amendment to HB 1381. We have raised these concerns with Delegate Young, and we hope we continue to work with him over the coming weeks. ACC recommends removing all references to PMDI from HB 1381, and these amendments will align HB 31 with the Virginia bill, which passed last year. I'm happy to address any questions. Thank you.
Thank you for your testimony. We have Mr. Andrew Dotson. Mr. Dotson.
Hi, thank you, Madam Chair. Good afternoon, everyone. My name's Andrew Dotson. I'm Vice President of Government Affairs at the American Wood Council. We are a national trade association that represents the wood products manufacturers in North America. I'd like to say a few brief remarks on HB 1381. First of all, we do want to recognize that firefighters work and train in extreme conditions, and consideration is needed for their health and their exposure to hazardous materials. AWC has a staff that works to develop state-of-the-art engineering data, technology, and standards for wood products to assure their safe and efficient design, as well as provide information on green building and environmental regulations. We actually employ a former fire chief and fire marshal and retain consultants to support science-based changes that are a quantifiable reduction in risk to firefighters. As a way of background, OSB is a widely used versatile structural wood panel that is found in almost all residential and commercial construction applications. These include subflooring, single layer flooring, wall and roof sheathing, structural insulated panels, and webs for wood eye joists. AWC has two concerns about HB 1381 as written. One was mentioned in the previous comments about the NIOSH study on which 1381 is based, and the type of OSB that was tested as not typically used for residential construction, and it's not certified by an inspection agency for use in residential construction. Also, we're worried about unintended consequences of HB 31, that this prohibition could be perceived as implying that OSB is not safe and should therefore be avoided in other applications as well. So we would like to see language added to clarify that this is not the intended consequence. A statement would help alleviate any confusion by consumers and the concerns of our industry. And this would also align, as was previously mentioned, similar language that was added in the Virginia bill in 2021. So thank you for your time.
Thank you for being with us, and we would encourage you to work with the sponsor. Thank you for doing that. We appreciate it. Are there any questions for this favorable with amendment panel? Seeing none, thank you so much for being with us today. We really appreciate your testimony. And colleagues, this concludes the bill hearing on House Bill 1381, and it concludes the work of the committee for today. Have a blessed evening. Thank you for your time. Bye-bye.